Good morning, Chairman.
Welcome to everyone participating in and listening to this meeting. I now ask Trina Coate to confirm the attendance of committee members.
Thank you, Chairman. I'd be very grateful if, prior to the start of the meeting, can I please ask members to confirm your presence when your name is called? Councillor Carl Macy.
Present.
Councillor Chris Brewis.
Present.
Councillor Susanna Barker-Milan.
Present.
Councillor Bill Bilton. Councillor Bill, thank you.
Present.
Councillor Matthew Fido.
Present.
Councillor Mrs. Sandra Harrison.
Present.
Councillor Mrs. Rosemary Cavery-Brown. I have heard her earlier. I'll come back to her. Councillor Rob Kendrick. Councillor Kendrick.
You've just asked me that. I'm present.
Right, I just didn't hear a response. Sorry.
Oh, sorry. Present.
Councillor Colin Matthews.
Present.
Councillor Robin Renshaw.
Present.
Councillor Glynis Scalesi. Councillor Scalesi.
Excuse me, it's Rosemary. I'm back.
Okay, thank you for that. Thank you, Councillor Cavery-Brown. Councillor Glynis Scalesi, you're present.
Present.
Thank you very much. Councillor Angela White.
Present.
Thank you. Councillor Mark Whittington.
Present.
Councillor Stephen Woodliff.
Present.
Councillor Ray Wotton.
Present.
And Dr. Brian Wookey.
Present.
Thank you very much, Chairman.
Thank you, Trina. Okay, before continuing, I would like to once again welcome everyone who is in this appointment and listening online to this meeting of the Health Scrutiny Committee. We've already confirmed which committee members are present. We also have present Councillor Mike Thompson, Executive Support Councillor for NHS Liaison and Community Engagement, and Dr. Cowley Chowdhury, Public Health Consultant for Lincolnshire County Council. Other participants will be introduced when we reach their item. I would like to ask members of the committee and other participants to type "speak" in the chat function when you wish to ask a question or make a contribution. Also, please turn off your camera and your microphone when not participating. Please keep your questions and contributions succinct and concise, and ideally no more than 2 questions per item. I would also like to stress the importance of treating all our contributors today with respect and to bear in mind our role as constructive scrutineers. I'd now like to move into agenda item 1, apologies for absence and replacement members. Nina.
Thank you, Chairman. We've received an apology for absence from Councillor Sue Woolley, Executive Council for NHS Liaison and Community Engagement.
Thank you, Trina. We'll now move on to agenda item 2, declarations of members' interest. Do members have any interest to declare, please? No? Should anything come up throughout the meeting, then please just type "speak" and we can raise it there and then. I'd like to move on to agenda item 3, minutes. I'd like to confirm the minutes of the meeting on the 20th of January 2021, pages 3 to 12, the agenda pack, as a correct record. I plan on taking these on block, so can I ask for a proposer, please?
Happy to propose those.
Thank you, Councillor Brewis. Thank you, Councillor Wootton. So they've been proposed and seconded. I'd now like to hand over to Trina Coate to do a roll call vote, please. Thank you.
Thank you, Chairman. Can members please indicate whether you are for, against or abstain when your name is called? Councillor Carl Macy.
For.
Councillor Chris Brewis.
For.
Councillor Susanna Barker-Milan.
For.
Councillor Bill Bilton.
For.
Councillor Matthew Fido.
For.
Councillor Mrs. Sandra Harrison.
For.
Councillor Mrs. Rosemary Caby-Brown.
I didn't attend, but I've read them.
Okay, thank you. So you'll be abstaining. Thank you. Councillor Rob Kendrick.
For.
Councillor Colin Matthews.
For.
Councillor Robin Renshaw.
For.
Thank you. Councillor Glynis Scalesi.
For.
Thank you. Councillor Angela White.
For.
Thank you. Councillor Mark Whittington.
For.
Councillor Stephen Woodliff.
For.
And Councillor Ray Button.
For.
So that's carried then, Chairman.
Thank you. So just to confirm, the minutes of the last meeting are confirmed. Thank you, Trina. We'll now move on to agenda item 4, the Chairman's announcements. Chairman's announcements have been circulated with the agenda, and my supplementary announcements were circulated on the 16th of February. I would like to raise a particular item at 1 on those, and that is recording thanks to those involved in the vaccines. I would like to ask the committee to formally record its thanks to all those involved, both staff and volunteers, in delivering the vaccination programme for Lincolnshire. I think that's something that we can all agree to. I do plan on taking the Chairman's announcements and supplementary announcements. So do I have a proposer that we note these, please?
Happy to do that, Jim.
Thank you, Councillor Brewis. Do I have a seconder, please?
Happy to second, Chairman.
Thank you, Councillor Wootton. Okay, if there isn't any dissent, we'll take those as noted.
Mr. Chairman?
Yes, is that Councillor Whittington?
Yes, thank you, Mr. Chairman. Is it okay if I just make a very short comment on one of the items on the Chairman's announcement?
Yes, certainly.
Thank you. It's in relation to on the Ulht Biviva surgery.
Yes.
Obviously, that is within my patch. Unfortunately, at the CCG meeting, they've approved the recommendation to close the Ulht branch surgery and transfer transfer it to the Stackyard surgery in Leicestershire. Is it possible to formally record that I'm extremely disappointed with that decision that was taken, and it's going to cause a lot of problems and difficulties for my residents. Thank you, Mr. Chairman.
Yeah, thank you. I'm sure that will be taken down. Okay, in which case it's been proposed and seconded. So there was no dissent. We'll move on to agenda item 5, and that is the Lincolnshire Partnership NHS Foundation Trust and NHS England and NHS Improvement CAMS Intensive Home Treatment. You'll find this at page 17 to 22 of the agenda pack. Before I introduce our presenters, I'll just mention again, if anyone who wishes to ask questions or contribute, please can you type speak in the meeting chat. I will take these at the end of the item. Now I'd like to welcome our presenters, Jane Marshall, Director of Strategy, Planning and Partnerships, the Lincolnshire Partnership NHS Foundation Trust, Andrew Horton, Lead Commissioner for NHS England and NHS Improvement, Specialised Commissioning, Midlands. So I'll hand over to you for about 15 minutes presentation, and we'll take questions at the end. Thank you.
Thank you, Chair. Hello, everyone. Good morning. My name is Jane Marshall. I'm Director of Strategy at Lincolnshire Partnership, and my colleague Andrew Horton from NHS England has joined me today. I don't know, Andrew, if you want to introduce yourself.
Hi, everybody. My name's Andrew Horton. I'm Lead Commissioner for NHS England Specialised Commissioning in the East Midlands.
So thank you for having this update today, Chair. We've previously attended the Lincolnshire Health Scrutiny Committee to update you on our plans and progress with implementing a new care model for our children and young people in Lincolnshire who have serious mental health problems. Colleagues will recall that the new care model we've updated many times, the committee in the past, we believe is working really, really well. And that is a model where what we've done is invest in what we've called an intensive home treatment team to support children and young people with serious mental health problems closer to home. That's been running for 18 months, and to fund that intensive home treatment team, we temporarily closed our inpatient unit at Ashvilla Rawsby to allow us to transfer both the investment and the staff into that new model of care. It's working really, really well for us. We reported to the Health Scrutiny Committee in July 2020 on the impact of the new care model and the fact that patients, families and staff are seeing really positive outcomes, measurable benefits for our population through that new model of care. The paper today, and following approval from the Health Scrutiny Committee in the past, we were asked to go to public consultation / targeted engagement on getting agreement to make that change to the new care model a permanent one. And this is underway as we speak and is led by NHS England, which is why Andrew's joined us on the call today. So I'll hand over to Andrew for him to take us through the process, what's happening, the timescales. Thank you, Andrew.
Hello, everybody. Thank you for that, Jane. Really quite brief, to be honest. We are undertaking our kind of consultation, and we've had some feedback to date. Some of that within the paper submitted, and the consultation closes on the 19th of February. And after then, we'll be collating all of that information to share.
Thank you, Andrew. So sorry about my network quality, everyone. We have included in the paper for you today the questionnaire and the letter that we have put out to everyone to engage and comment on this proposed service change. So whilst there are only a couple of days left, we would really encourage people to give us their feedback, and for you as councillors to encourage people in local communities to give us that feedback. And we are committed, Chairman, to bringing a future report to this committee on the outcomes of the consultation so that we can engage fully with the Health Scrutiny Committee on the outcomes of that work. Thank you, Chair. Back to you to take comments and questions.
Thank you, Jane. Thank you, Andrew. I've got my first speaker, which is Councillor Robin Renshaw.
Thank you, Chairman. That was quick. Yes, it's on page 18, and on the comments from service users, said it was good that she didn't have to keep on repeating herself that she has to do in other services. It's just a comment across the whole spectrum. We've had this anomaly over public services over the last decade, and it's gone on. And I thought that was standard practice. So I'd like reassurance that it's going to be commonplace across the NHS and across the county council. But that's for Friday, isn't it, everybody? Thank you.
Thank you, Councillor. If I may respond, Chairman, is that okay?
Certainly.
Thank you. You're absolutely right. The feedback we get from lots of patients, people using our services, is that they have to tell their story more than once, and they find they repeat their story very often. And sometimes that's quite traumatic for people, particularly when they're suffering with their mental health. So as part of all our work, we're working really hard to make sure we support people so that they only have to tell their story one time. And in the children and young people's service that I'm speaking about today, we've put a children and young people's This Is Me passport together, which includes all of their key information, so they don't have to keep repeating their story. And that's working really well for us. Because there's one version of that document which, if a young person doesn't feel like repeating, they can just hand that document over or share that with whoever they're working with, and that has all the information that there is about that individual. It's really important that we get it right, and we're working hard to do that, not only in children and young people's services, but in all of our services. So thank you for the question. I hope that gives you some assurance that we're on it.
Thank you, Chairman. Just make comment. Obviously, when people are at the lowest ebb, they've just been needing emergency intervention. It's so very, very important, not only for the mental health and for the physical health and prospects of recovery. So, and having been through it, I know what it's like. Thank you very much, and thanks for your answer.
You're welcome. Thank you.
Thank you. Okay, we have Councillor Whittington next, please.
Good morning. Thanks, Mr. Chairman. Thanks, Jane and Andrew, for the report. I've got a very, very simple question. Obviously, as you said, Jane, this report came to us last July, and I think the general consensus of the committee at that point was they welcomed it and they thought it would sort of be an improvement, in service. Obviously, at that time, we were 3 months into COVID, and I know we've become increasingly aware there's been lots of reports out there that are sort of saying that the mental health of everybody seems to be suffering as a result of COVID. It's really just a question around post-COVID. Do we think that if potentially there is going to be a fallout from COVID in terms of increased service needs of young people with mental health difficulties, that we think the current service will be able to manage any post-COVID increased demand? Thanks very much. Thank you.
Thank you, Councillor, and thank you for raising that really important issue. Andrew, just let me know if you want to come in. We are very, very aware and working really hard to plan for the impact of COVID on our children and young people's mental health and physical health. We're really concerned about it because we all know, don't we, that for children and young people, they're our future, and we need to get it right for them to really seriously think about how we support people through the impact of COVID-19 and all of it that it's done with young people's education, their support networks, their ability to see their friends, etc., etc., etc. All of those things obviously impact on well-being. So our teams, I have to say, we benefit in Lincolnshire from really good children and young people's mental health services. They're integrated across the pathway, as we call it. I'm sorry for the technical language. We work with schools very closely as a mental health organisation. We're supported by our commissioners at Lincolnshire County Council to do that. So we have an integrated pathway for every point at which a child or a young person could enter the system of mental health care. And our aim is to make sure that every child or young person who needs a service gets one. And our staff work really, really hard to do that. I recently attended a celebration event where all of our staff were together looking at all the developments they've put in place for children and young people to deal with the COVID impact. And those include some really exciting things like more work with schools. They include digital and online options for children and young people to access support, because obviously for that generation, I think it's really important to have the right resources online for them to access, to support them. We've got a helpline in, 24/7 mental health helpline specifically for children and young people, so that any child or young person or family with a concern can get help at the end of a telephone immediately, 24/7. And we're working on a plan to put even more in place in partnership with our commissioners. We're really aware of the potential impact of COVID, and I think we'll be working on this for a number of years. This won't stop in the next year. It will continue for a long, long time. And I think that's where this new model of care is really beneficial, because we've already done work to make sure it's a community-facing service that's available across our county for everyone who needs it. So I think that idea of ensuring that communities have the right resources, have the right services wherever they are in our geography to allow people children and young people and families to get access is really important. And I'm proud of what we've done working in partnership with our commissioners. And I don't know if Andy wants to comment on that from a NHS England point of view.
Yes, thank you, Jane. I think in terms of the question, it's a regular conversation we have with all of our trusts and all of our health systems across the East Midlands about, you know, we recognise that the last year and a bit has been unprecedented in terms of the impacts upon communities and health systems. We're kind of quite really pleased about the innovation with this project, because actually what it does is it pushes everything towards home. And right now everybody is at home. I appreciate that the contact and opportunities for young people and their families to contact is reduced because of the closures around attending school, etc., etc. But I think that the work that the trust has done in terms of trying to embed itself within the different systems and community groups is a real benefit for the project going forwards.
Thanks very much. I'm extremely reassured by the comments I've heard, especially the acknowledgement by Jane that this is not going to be something that's going to be solved in a few months. It's going to take quite a number of years to actually resolve and for us to become fully aware of the impact. So thank you very much indeed. Thank you.
Thank you, Councillor Whittington. Thank you. Okay, Councillor Kendrick, you're next, please.
Thank you, Chairman. I was just wondering, Jane, what the sort of response rate's been to the sort of survey. I take it all the sort of service users have been mailed out with the survey form. I was just wondering what the sort of level of response was. Thanks.
Thank you, Councillor Kendrick. Nice to see you. I know that we've not had a huge number of responses, but we have emailed and advertised widely the opportunity to participate. I think partly we've done quite a lot of engagement anyway. We've been to this committee a number of times to talk about this service development. So we have done an awful lot of engagement work pre-consultation. And some of the feedback in the paper that Andrew's put in is examples of positive comments we've had from that pre-engagement work. I would be very happy to bring to the committee at a future date, Chairman, if you wish, a full report that includes all of the pre-engagement work, all of the comments we got then, and all of the comments we get from the consultation. It might be that there aren't many as part of the consultation, but I think if we see the whole thing in the round, that will help us navigate the decision that hopefully you'll support us with.
Thank you. And yes, that'll be very helpful. Thank you, Jane. Okay, do I have anyone else that wishes to speak still, please? No, in which case I have a number of questions as well. So I'll start with my first, and that is, how are staff vacancy rates for CAMS?
We're doing really well, touch wood, thank you, Chairman, with our CAMS teams. And I mean, we do have challenges with recruitment. We have challenges with particularly qualified nursing staff. But the beauty of the CAMS teams is they are really comprehensively multidisciplinary. And the celebration event that I talked about really demonstrated that. We've got peer support workers, we've got experts by experience, we've got qualified nurses, psychologists, therapists, medics in a multidisciplinary team. So touch wood, whilst there are pressures on recruitment, we are doing okay with our child and adolescent mental health services. We are constantly looking to bring people in where there are vacancies, and we've got some active work going on as part of the Be Lincolnshire campaign, which is a Lincolnshire system-wide campaign on recruitment. So yes, I think we're on track and doing okay. Thank you for the question.
Okay, thank you for the answer. When will the evaluation of the pilot exercise be available to the public?
I think Andrew might want to take that one. I'm keen to do it as quickly as we can, so we can bring it back to the committee in the next couple of months, if that's possible. I don't know if Andrew's got any thoughts on that.
No, thank you for that, Jane. I think that would sound like a reasonable timescale. We've got the consultation. Once we get all of the feedback, then we can pull that together and work with our colleagues within the trust and also within our wider East Midlands Children and Young People's Provider Collaborative that's due to go live on the 1st of April, and they'll be kind of supporting the trust around that. And I think that the learning from this model has been really useful in terms of informing future provision across the East Midlands for young children and young people.
Thank you. So if we say probably around about June, if you come back, that'll probably be best after the election and everything's out of the way. So, okay.
Sure, thank you.
Thank you. On page 18, the third paragraph, it states that general adolescent units are out of scope at this stage. Why is this, and when will they be in scope?
It's non-general adult units that are out of scope for the Lincolnshire model. So the work we've done so far, Chairman, is around children and young people that go into that general adolescent unit group. The difference is essentially there are a group of children and young people with non-GAU needs who have always, because of the nature of their needs, always gone out of Lincolnshire for their care. So an example of that is a young person with an eating disorder, where in Lincolnshire we don't have an inpatient unit that would meet those needs. So we would always have transferred those children out to specialist centres, in this case in Leicester. So that group of children, we will be looking at options for those children as part of the provider collaborative that Andrew mentioned. So they're not forgotten about. We are working hard to make sure they get the best services that they should do as well. But our project in Lincolnshire specifically applies to general adolescent unit children. And if it helps, I can send you some definitions of that just to guide your thinking, because I appreciate its technical language.
Okay, thank you for that. Just following on from my last question. Sorry, Andrew.
Sorry. I think we just want to let you know that actually there has been an impact of this model upon some of those other admissions. So in terms of children and young people who require specialist eating disorder units, we've seen since the kind of inception of the project that we've seen about an 80% reduction in the use of those services. So I think the benefits of engaging with young people and their families very early in that process, seemingly the current evidence is showing kind of an impact along all of those other kind of service lines that we can commission.
Thank you, Andrew. Okay, just following on from the last question, on page 21, the final paragraph, it states that inpatient care could be provided on another site within Lincolnshire. Where is this site likely to be if it was to go ahead?
I think that would be, Chairman, for decision if the outcome of the consultation suggests that an inpatient unit is required in Lincolnshire. What we know from the work that we've done is the previous inpatient unit at Ash Villa did not meet the specification that our commissioners at NHS England set for such a building. So there's no decision on any particular site, but we are aware that if the consultation said people want an inpatient site, we would have to look at where we provide that, and it would have to be a different site to the previous one at Ash Villa.
Okay, I've only got one final question, and then I've got Councillor Woodliffe that wants to come in. So, should the decision be made not to have an inpatient site, how do you propose to support children and their families in regards to transport and accommodation if they say have to be out in Leicester or somewhere similar?
Thank you. That's a really important question that we've discussed before. So the way we would look to support children and families is to do everything possible we could to prevent an admission at all. And the community-facing service has proven really successful, as Andrew's just said, in reducing the number of children and young people in Lincolnshire who need an admission. And the reason it's successful is it's responsive. We support families early on in the deterioration of their child or young person's mental health. We have had a small number of admissions, and if at the moment with this model, if a child needs an admission, they travel out of area. We are working with the provider collaborative in the East Midlands to make sure if a child needs an admission, they don't travel beyond the boundaries of East Midlands if we can help that. And the provider collaborative is yielding really good results as we work in partnership together to make sure that if a child does need an admission, say to Leicester, we bring them back home to Lincolnshire as quickly as we can. So that provider collaborative, it may be that you would require a further update, Chairman, at a future meeting on the work of that provider collaborative at East Midlands level. It's horizontal integration of people, horizontal integration of services across the regional footprint. Really, really important work that we probably should share with you at a future meeting if that's appropriate.
Yeah, I think that'll be very helpful. Thank you. Okay, Councillor Woodliffe.
Oh, thank you, Chairman. Thank you, Chairman. Sorry about that. I couldn't get the thing to work. This happens. I'll try and get my camera up if I can. Not for the, oh, okay, thank you. Right, now I have a question, Jane. I believe that I wrote to you after our last meeting, and it concerned the relationship between GP practices and patients, and I think it was to do with the transfer from child or young person to adult, the relationship and the relationship there. I didn't receive a reply to it, but I've been trying to search for the letter in the last 10 minutes. Unfortunately, I have not succeeded in finding it yet. Did you receive a letter from me?
I don't recall it, Councillor. If I did, I apologise for not replying. I have done some work on the back of the question that you asked me, and I can provide you with an update in response to your question. The work that my organisation does with GP practices is really important. So we've put a programme of work in place to improve the interface, if you like, between LPFT's clinicians and clinicians, doctors in GP practices. But I can explain that in a letter to you if that would be helpful.
I think that'd be helpful. I think it was to do with the transfer from young person to adult, because when they get to 18, they switch from being in the children's services to being in the adult services, I suspect. Is that right? And therefore I think there was a problem about the transfer, but I can't quite remember.
That's correct, yes. Well, that's an issue in all services. We label it as transition. So transition between children and young people services and adult services. But part of the work that I'll write to you about is how we've been strengthening those processes. So in very simple terms, the team that's picking up the young person aged 18 or over works in advance of that 18th birthday with the team that's currently got them in their young person service, and we're looking to extend the age definition, because not all young people are ready to transfer to adult services at 18. It might be that they're 22 or 24 before they're ready. So I can explain that in more detail, the work that we're doing to make that transition very smooth and meaningful and engaged with the patient. I can explain that to you in the letter I send you.
Well, thank you very much indeed. I do apologise for coming in late. But it wasn't until I started the meeting that I suddenly recalled the conversation we had. So I've been spending the last 5 minutes trying to track the letter down, but unfortunately I can't seem to find it on the system. So I do apologise for that, and I want to thank you, Chairman, for allowing me to come in late. I do apologise for that.
No problem, thank you. Well, I have no further speakers, so I would like to move to a proposal that we note the joint report from Lincolnshire Partnership NHS Foundation Trust and NHS England and NHS Improvement and the CAMS intensive home team. I would also like to propose that we receive a further update in June to include outcomes of the engagement and out of area placements. Do I have a seconder for that proposal, please?
I'm quite happy to second that, Chairman, and I think as well we all know this is going to become an enormous problem in the coming months. Thank you, Chairman.
Certainly. Thank you. Okay, I plan on taking the proposal by dissent. Please indicate in the chat function now if you dissent from this. If not, I'll confirm the decision. No, I'll take that as a decision confirmed, and I would like to thank both Andrew and Jane for the presentation. Now I'd like to move to agenda item 6, the LPFT General COVID-19 update, which can be found on pages 23 to 32 of the agenda pack. Supplementary chairman's announcements also refer to the closure of Ashley House in Grantham, and I would ask that Jane Marshall covers this in her presentation. So if I can hand back over to you, please, Jane. And again, if you can do it in around about 15 minutes, and we'll take questions at the end.
Thank you, Chairman. Thank you for receiving this update report from Lincolnshire Partnership Foundation Trust. This is a paper prepared by our acting Chief Executive, Sarah Connery, that she presented to the Lincolnshire Partnership Board on the 28th of January. And you'll see it's a comprehensive picture really of some of the work of the Trust, which we take at our public meeting as part of our accountability for the work that we do. So we describe in the report, as you'd expect, the response of our fantastic staff to the COVID-19 situation, and I would like to place on record the fact that our staff have obviously really responded brilliantly to the pressures that have been on them over the last year. And not only have we been able to manage the outbreaks that we've had to manage as an organisation, not only have we been able to keep our patients safe, but our staff safety as well obviously has been important to us. And not only that, we've not stopped making progress on some of our transformative work and changing services for the better, even though our staff have been dealing with the pandemic, which is credit to them really. And you'll see in this paper some of the work that we've been doing as part of our developmental work and transformation work. So we have had to take some difficult decisions about our capacity as we've managed the outbreaks. To date, we've had 6 outbreaks. We're currently managing one. This report, when it was written, we had 5, but we've had 6, and we're currently managing one now. One of the decisions we had to take is detailed on page 25, where we had to temporarily close our psychiatric intensive care unit, which is on the St George's Lincoln site, for a period of time. But we flexed our capacity depending on the need and depending on the need to be safe. So that reopened that unit on the 14th of December. It says 2021 there in the paper. That's an error. It should say 2020. It reopened before Christmas. We've participated in the vaccination programme as an organisation and been proud to be part of the Lincolnshire vaccine response to our very high clinically risk cohorts of patients and to our staff, and are proud to have worked in partnership with our NHS and other partners on making that a success, achieving some really good results for the staff and patients of Lincolnshire through that programme, as I'm sure you're aware, Chairman, through other sources of information that you have. We're also proud to say that we achieved a 92% take-up in our staff group of the flu vaccination. If you remember that, before the COVID one came along. So really, real credit to our staff that they see the reason to take up the flu vaccination, and we're among the top performing mental health organisations in the country with that 92% uptake. And a brilliant result for our organisation, because obviously a really good way of keeping staff and patients safe and preventing deaths, actually, because obviously every year a number of people die from influenza still. We've mentioned the work with the East Midlands Provider Collaborative, so I'll not labour on that, but I would suggest maybe, Chairman, that the committee considers receiving a future report on the provider collaboratives, because several have gone live, including the impact one, which is mentioned in that report. We've just talked about the child and adolescent mental health work at regional level, and also our adult eating disorder services have gone live as well. So I think it'd be really important if you're willing to receive a future report about that at an appropriate point. Yeah, we're making progress on. Sorry, thank you. I think, just so that I don't talk for too long, in the middle of page 27, really important piece of news for Lincolnshire, in that we've been, as an organisation, we've been awarded £37 million. Councillor Kendrick will be really interested in this, to eradicate the non-fit for purpose dormitory accommodation and inappropriate bed spaces that we still have on some of our wards. Those dormitories do not meet modern standards for privacy and dignity, and this substantial funding means at last we're able to invest to get rid of that poor accommodation for our patients. It also gives us exciting opportunities, so we are looking at investing some of that money in the Boston area, because some of those wards aren't fit for purpose. So really important that we're able to invest not only in Lincoln at the Peter Hodgkinson Centre, but also in our Boston services as well. So some exciting potential developments as we work as a system. We all work together to take the best advantage of investment in our county. I mentioned there at the bottom of page 3, Chairman, repurposing Ash Villa and the Wolds, which is one of our long stay rehabilitation wards at Discovery House in Lincoln. And if I may, at this point, may I speak about Ashley House in Grantham, which is linked to that piece of work, and I know you wanted me to pick that up as part of my comments today. Is that okay to take that
very
now?
Helpful, thank you.
So at the bottom of page 3, you'll see there, and I've updated the committee before, we've been working really hard to make sure we have the inpatient capacity to bring back the 15 female patients who are still out of area, Lincolnshire residents who are being treated away from home for some of the complex mental health conditions that we support people with. So we've been repurposing Ash Villa while it's been temporarily closed into a 15-bed acute ward to take some of those patients back who are currently out of area and bring them back. We are required to have no patients out of area inappropriately by April this year. So those 15 beds at Ash Villa are absolutely crucial to us in achieving that outcome for our patients. And it's a really important one, because we know that the quality of care those people receive is much better if they're closer to home, so their network of friends, family, etc., closer to them, nearer where they live. So really important that we get those people back. We have a plan. We've upgraded Ash Villa. It is had some capital investment to make it more fit for purpose in terms of accommodating that patient group. And we have been recruiting into Ash Villa for a number of months. We've been successful with that, but the area, the staff group that we've had the most problem recruiting is our qualified nursing staff at band 5. So we've had to really think creatively about where we get those staff from in order to staff Ash Villa, in order to get those out of area patients back. And that's why we've had to take the really tough decision to temporarily close Ashley House in Grantham, because Ashley House is only 50% occupied at the moment. So there's 15 beds, but only 7 patients in there. It's an all-female unit. We've been redesigning the pathway to get those patients in back home. And so we've had to take the difficult decision to transfer and redeploy some of the staff at Ashley House to staff Ash Villa. Ash Villa is at Rawsby, and it is a difficult decision, and really conscious that it's another temporary closure, and it's a temporary closure in the Grantham area. However, you will know from the numerous times that I've been to this committee, we've had to take some difficult decisions over time that you've supported us with in order to transform our services, but also address other patient safety issues that we've got elsewhere. And that patient safety issue and quality issue with our out of area patients is really, really important to us. I hope that makes sense, Chairman. Obviously happy to, I realise that's quite a lot of detail, so happy to take challenges and questions about that. And then just finally, just to say that, again, another area of interest to the committee was the Longleys Court and our learning disability service that we've obviously been to the committee with in previous reports. The section at the bottom of page 4 confirms the publication of the Independent Safeguarding Adults Review into the incidents at Longleys Court, and our Board of Directors took that report in public, and we've obviously been very very keen to apologise to the people affected by that learning and those events at Longleys Court and their families. So really important, I think, that we highlight that today. I'll pause there, and I'm obviously happy to take any questions from the committee. Thank you.
Thank you, Jane. Okay, I've got Councillor Whittington first, please.
Thanks very much, Mr. Chairman. Thanks, Jane, for the very comprehensive update. I've got a number of questions, and obviously I've got an extra one now in relation to Ashley House being a Grantham councillor, but I'll ask the other ones first. On page, and I know we've just agreed, the first question is relating to the provider network, and I know that the chairman's asked you to, and you're going to bring a future report. I've just got one question. Obviously, I have to admit that I worked for 10 years for the East Midlands Specialist Commissioning Group, which became part of the NHS England team. So I've been on the other side, as it were, and I know then that certainly with a lot of providers, especially around mental health, there's an awful lot of private providers that are in the area of providing care. Do the provider networks just include other NHS providers, or do they include working with private sector providers that are out there? Second question is on the integrated care systems, and I know at the moment I kind of get the impression that you're not entirely sure at the moment whether the integrated care system will be just a Lincolnshire wide one, or maybe a wider East Midlands one. I'm just wondering if you could just give us a little bit more information on that, and if it's possible, share some of the issues you've been raising with the national NHS. Third question is on the dormitory accommodations. I was actually quite surprised when I read that to see that you still had dormitory accommodation. I'm presuming that post developments. I'm assuming, and we confirm this, that in future each patient resident will have their own room. But if that is the case, I'm just wondering then, obviously, if people are in dormitories, it's a lot easier to kind of monitor. I'm thinking about suicide risk and things like that. And I'm just wondering, obviously, if patients sort of do have their own rooms, what sort of precautions are going to be in place for the safeguarding of patients. And I have been round some mental health units when I was working in the NHS, and I've seen what can be done in terms of being able to obviously give patients a certain amount of their own space, but also the monitoring to ensure that they don't self-harm or whatever. So that'll be quite interesting. And then the final one is on Ashley House. Obviously, yes, it is a bit disappointing that another unit in Grantham is closing, albeit on a temporary basis. But in terms of, I think, of what you've described, I think it's a case that you probably don't have any other options other than to do this. My question really is around the 7 who have been displaced from Ashley House and have gone, I'm presuming, back home. I'm just wondering, will there be sufficient sort of capacity out in the community? Because I'm presuming they're now going to be receiving community-based care. If there's sufficient capacity to incorporate them, and potentially would some of those 7 potentially end up in the new Ash Villa development when it's completed? And I appreciate, because as I say, I've been in the health service, and I know that out of county provider tend to be more expensive. You tend to lose control. It's very hot, and also the patients are more isolated. So I think the decision to bring them back in county to Ash Villa is a really good one. It will obviously, benefit the patients, and also I would imagine save the trust some money. But it's just a little bit of reassurance around those who've been displaced from Ashley House. Thanks, Mr. Chairman.
Thank you, Councillor. So I'll briefly try and respond, and I'm very happy to provide additional information. The patients who will come back out of area into Ash Villa are females. So at the moment, there's an inequality in health in that our male patients we can bring back because we've got a unit. Our female patients we can't. So through opening Ash Villa, not only are we improving the quality of care, but we're also putting right a current inequality of access, which is really important. So that will be a female-only unit. Yes, there is sufficient capacity to ensure that the 7 females currently at Ashley House are safely placed, and they may well, and the planning for that is going on, so that we make sure everybody, all of those 7 patients are safely placed in the right facility that meets their needs. You're absolutely right. Some of those people may end up being at the sister rehab unit in Boston, Maple Lodge. They may go to Ash Villa, or they may go into our community rehab team, which is a rehabilitation team, which is a at-home community rehab service. And bear in mind, Ashley House is an open rehabilitation unit where we're essentially working with our clients there to get them ready to go home and live independently. So that's the whole ethos of that building, that service at the moment. I share your concern about Grantham, and to give assurance that we are conscious of the fact that we're talking about Grantham, but really willing to engage with people and seek their views on the impact of that temporary change, and we'll be reviewing it on a monthly basis. Chairman, if you wish, I could provide you with a monthly update report on how that's going, that temporary closure is going. If it doesn't meet what we're expecting it to meet, then obviously we'll review that decision.
That'd be very useful, I think. Thank you.
Yeah. The 37 million and why we still have it, we still have dorms because we've not had the investment so far to set them right. So that 37 million is really good news. I can give you full assurance that in creating single rooms for our patients, we do not compromise at all on patient safety with regard to any suicide risk that those patients might have. So we have absolute protocols and safeguards and observation policies and an approach that keeps our patients safe. The key thing with dorms is that they do not offer dormitories, sorry, Chairman, they do not offer a dignified option. If you are sleeping in a dormitory where there's only a curtain between you and the next patient, that is not a dignified situation for any of us, particularly I think when you're dealing with some of the complex mental health issues that our patients our patients have. So I can give you full assurance that it's a patient safety issue, and we absolutely won't be taking any risks with patient safety. But it's good news as well to get that investment. ICS, I can circulate the response that we've made as an organisation, and I think it may be, Chairman, that as a system you ask the health system to link with you at a future meeting. NHS England and the provider collaboratives work on a partnership agreement basis and do include potentially NHS providers, but also private providers as well. But in signing up to the partnership, you're signing up to a set of principles that governs the work that you do. And it's a really strong feature of our work at East Midlands level with our private provider colleagues. I think that answers your questions, Councillor. Sorry to take so long.
That's fine. Thank you for that. I'll make sure it's picked up on the work programme as well, Councillor Whittington.
Yeah, it's fine. It's fine, Jane. I'm happy with the response I've got, because I certainly know when I was working for the NHS and we were engaging in contracts with the private providers, they had to provide us things like their health and safety policies, their staffing rotas, and all this kind of stuff. So we were assured that they were receiving the same level of care with the same level of staffing, the same sort of staff mixes, as if they were in the NHS, and we were really thorough. So I'm really pleased with the comments. Thanks, Jane.
You're welcome. Thank you.
Thank you, Jane. Thank you, Councillor Whittington. Dr. Wookey, you're up next, please.
Thank you, Chairman. Jane, just two queries. One relates to your report, where you mentioned quite rightly the support you've given to staff over COVID. But there isn't anything there relating to patients in general, both during and after COVID. And I think something that is in the pipeline, which has already been warned about, is that there's going to be an enormous amount of community work, both in mental health and in physical health, relating to people who are either got post-COVID or they have developed mental health problems from stress of families, etc., which I'm sure you're very well aware of. And the question really is, how much integrated care are you planning, and with your colleagues in LCHS and primary care via the CCG, to provide a service where people are not just going down their own silos, they are working together, because there are very few patients who have not got some mental health interactions from the stresses that they've had, and the people who have this long period often with their physical rehabilitation, who also need mental health support. So that was the first question. And the other one, just very quickly, related to, you've already mentioned about CAMS, and I know I've asked you on behalf of Healthwatch once or twice in the past about the fact that we are still getting feedback about the wait for CAMS and the isolation some of the young people feel while they wait. There isn't criticism about the actual care, it's just waiting for the care. Given that that is probably likely to get worse rather than better, then I wonder whether you could just provide some reassurance that that's also on your radar, as indeed is the transfer from CAMS to adult that Councillor Woodliff has mentioned. Again, something that we have had feedback in the past about. So we're very interested in your response to Councillor Woodliff on that.
Yes, thank you.
Thank you, Jane.
You're welcome, Councillor Wookey. So I'd be really happy to bring a team to Health Watch to explain those issues around CAMS if that's appropriate. I think it'd be really good to hear some of the great work that our CAMS teams are doing on that integrated pathway. I can give you assurance that we are meeting our waiting time targets for CAMS, Child and Adolescent Mental Health Services. We did have to do some work to catch up with that, but we're currently meeting those standards for our patients, and they're quite stringent standards. But you're absolutely right. There is something about working with our primary care colleagues and the CCG to improve the conversations, I think, early on about children and young people who might be experiencing difficulties. So we're working through the clinical interface group that I mentioned before with our primary colleagues. And again, I'd be really happy to provide an update on that work as it progresses. With regards to supporting citizens out there who may be affected by COVID, you're absolutely right, Councillor Wookey. We're anticipating, and we all know it, don't we, a big surge in the number of people who need support. So what we've tried to do to anticipate that is put in place some community assets that will help. So for example, we've put, again, a 24/7 mental health helpline in that's available for anyone to call who might have a worry about their mental health. That's provided by a specialist, a voluntary sector partner, Mental Health Matters, and that signposts people. It's linked to 111, and it signposts people who want help to the right place. That right place may be Lincolnshire Partnership Services, but it might be another community group or community facility or support group that's available. And that's working really, really well. We've got some good results from that. And you may recall we were successful in Lincolnshire at LPFT, working with our clinical commissioning group colleagues to secure some community transformation money in sort of September 2019, and we've just bid again to roll out that programme of work on essentially putting things in place in local communities like better links with primary care, social prescribing. So in the same way we get a medicines prescription for the drugs that we might need to treat a condition, a social prescription is one that says these are the activities you need to keep you healthy and well. So that might be exercise, that might be activities, that might be support. So we've got some more investment to roll that out and get that in place across Lincolnshire. And again, it's one of those things that you may as a committee want us to present to you in the future, because it's a really good example of integrated working where we've worked with voluntary sector, with our primary care partners, with primary care networks, with the CCG, to really think about that offer that we make now to our communities to help to keep them safe and well. And a really good example of integration working now for Lincolnshire. So again, I'd be really pleased to bring that forward. I feel like I'm bringing a lot to future meetings, but I think it's important the committee hears about some of that work. Thank you, Councillor Wookey.
Thank you, Chairman. I haven't actually been elevated to be a councillor, but thank you. That's very helpful.
Oh, I'm so
Jane.
sorry. I'm sorry.
All right. No problem.
Thank you, Dr. Wookey. We'll pick again that up in the work programme towards the end of the meeting today. I have two speakers left, and then I have a couple of questions myself, so I'll be closing down the debate at that point. So I've got Councillor Kendrick next, please.
Thanks very much, Chairman. great news, as Jane has said, about the extra funding for accommodation. I mean, it seems amazing that in the 21st century we still have dormitories in some of our units around the country. So that's fantastic news. I was just wondering whether the accommodation over at Boston, whether that will now become ground floor accommodation, because as Jane knows, having two wards at first floor level was not at all satisfactory. So I would hope that that's going to be a ground floor thing. It is brilliant. That's great. And another one was at Ash Villa. Is there any thought that perhaps because it's quite an isolated unit, that's sort of not made it quite as attractive as some say on the St George's site or at Lincoln County site? I was just wondering whether that's one of the sort of stumbling blocks as regards recruitment. I was very interested about the Wolds, and I would certainly like to learn more about the personality and complex trauma team. That's I have to admit, that's a new one on me. So I would certainly be interested in the role of that, and also how things have changed to reablement as opposed to rehab. I think that would be quite interesting. And finally, on long leads, it's good that the report's come out and it's public. The only thing I've noticed, and obviously, you can't go into detail on this, but I noticed there's no mention, unless I've missed it, of any sort of disciplinary action taken against staff on this one. I mean, we'd hope that the staff perhaps have had retraining or redeployment, just they're now doing things in the right way, as opposed to obviously what was thrown up by the investigation. So thanks very much for that, and great news again on the award of being one of the top trusts. I thought that was fantastic news.
Thank you very much. Would you like me to respond to those, or are we running out of time, Chairman? I'm really conscious of time.
Please. I mean, Councillor Kendricks touched on part of a question I want to ask, so if I could just hold on that before you answer. And that is, can you tell the committee what areas of Lincolnshire are currently covered by the personality and complex trauma team, and also the community rehabilitation service? And when you'll receive the results of the bid to help you in rolling this out throughout the county as well, please. Thank you.
Thank you. So the areas for the personality and complex treatment team have to now been the four initial rollout areas that we had, which were Grantham, Lincoln South, Gainsborough, and I can't remember the fourth one, but essentially a third of the county, Chairman. The proposal we've just put in has received approval to extend that packed service to be a county-wide service. So that's confirmed, and that is a new service for people who live with a personality disorder, which was a huge gap before in what we were able to provide in Lincolnshire, as Councillor Kendrick will know from his experience with the Trust. So that's really positive. If we come back to the committee with a presentation on community transformation, that would include the packed service, as well as the community rehab service, some more investment in eating disorder community services that we're planning, as well as social prescribing, more capacity in our community mental health teams. And we'll be able to give you a sense of how we're rolling out that across Lincolnshire, so we have the services available for everyone who needs them. And that is so important, that we develop our services and we develop the models maybe in part of the county, but as soon as we can, we roll it out so everyone has access across Lincolnshire. The point about Longleys Court, I can give assurance that there was a full action plan which picked up everything that review raised, and that's been fully implemented by our trust in partnership with our regulators. So I can give you that assurance. Asheville are being isolated, so we can't get the staff. It's not that we can't get qualified nursing staff to apply for those jobs. It's a particular group of qualified nursing staff, so our band 5 nurses who I think are in short supply. So that's why we're having to move staff around, and that's why we're working hard with the universities and others to retain those nurses who tend to train in Lincolnshire, but then maybe move to other counties, to, you know, the bright lights of wherever. So we're trying to say, look, stay with us in Lincolnshire. It's a great place to be. It's a great place to live and work, and to sell that through the Be Lincolnshire campaign that I can send you the link to if you wish to see that. I hope that answers the questions.
Thank you very much, Chairman. Thank you.
Thank you. Yes, thank you, Jane. I've got Councillor Brewis, and then I've got just one last question.
I'm just going to say how the fact that we've got an increasing problem coming, Chairman, I'd like to say how much I've appreciated and enjoyed this presentation, and strength to your arm rolling it out. It's going to be an increasing problem, partly caused by the education system now having a national curriculum where everyone has to be treated alike, and we forget. And anyone who's never suffered a mental problem, possibly a lot of them don't realise that they are individual problems. They're not all the same. There's no two ones that are alike. I would particularly like to say strength to your arm, particularly in the southeastern corner of the remote parts of the county, where in some ways the problems are going to be even more marked because of the remoteness, and particularly in generally the fens, where we have young people who rely on their contact with others and live in very remote properties which are scattered all over the landscape, which doesn't happen in upland countryside. We have houses scattered all over the landscape. I've had a number of people contact me, and I've put them in touch with the correct thing in the last year, although in 2 cases involving 4 young people, I decided I'd try and help them, and they've both now had reports from their school congratulating them on working independently, and it was by treating them as individuals. And I think that is your most difficult job, if I may ask you, is the fact that there are no 2 problems which are alike, and until you uncover them, you don't know what the problem is. Am I probably right in that?
I think you probably are, but I think that's one of the things we do well at Lincolnshire Partnership. We have fantastic staff who recognise that we need to provide holistic care for individuals, and that's what we value and that's what we believe in. And we have outstanding child and adolescent mental health services in our county. It's a great place to be, and you don't get that for no reason. It's absolutely testament to the staff who provide those services.
And I'd particularly like to put on record my thanks for what you do for a lot of people. And I also think what isn't sometimes realised is there are a number of foster homes who do the most extraordinary job with extremely difficult problems. And I have nothing but the deepest admiration for what they do, because it's quite extraordinary what a limited number of people are doing with some of our most troubled young people. But strength to your arm, and thank you very much.
And I think just to say, this is in partnership with our commissioners, Councillor Brewis, Lincolnshire County Council and our NHS Lincolnshire Clinical Commissioning Group colleagues have driven the improvements from a commissioner point of view, and it's work in partnership, but it is absolutely co-production at its best between commissioner and provider.
Thank you, Jane. I've just got one final question, and I think it's been partially alluded to as well, but that is in regards to the recruitment to nursing posts. You said that it still remains a challenge and you've tried various recruitment drives. Have you opted for any overseas recruitment? And if not, is this something you'll now consider?
We are looking at it, Chairman. We've not particularly looked at that as an option prior to now, but it's part of the suite of things that we're looking at to try to attract nurses to come and work with us. And any support this committee can give to us getting those messages out about it's a great place to work and be would be appreciated. But yes, we're looking at overseas recruitment of nurses and of medical staff as well.
Thank you, Jane. I'm sure that committee members will feed that out to the parishes and whatever newsletters they do and so on. So we'll certainly do our best for that. In which case, I'd like to move to the proposal, and I would like to propose to thank all staff at the Lincolnshire Partnership NHS Foundation Trust for their efforts in response to the COVID-19 pandemic. Propose we receive an update early in the new council term to include the provider collaborative report, and in the meantime receive monthly updates on the closure of Ashley House. Do I have a seconder for that proposal, please? Thank you,
Happy
Councillor.
to second that, Chairman.
Thank you. In which case, again, I'll take this by dissent. If there is any dissent, please show in the chat box. In which case, I'll take that as carried. And once again, I'd like to thank you for your attendance today, Jane. It's been very, very interesting. There's lots there that we'll have picked up as well in the work programme. That's why I think I might have taken a while with my proposal to include it all, but thank you very much. I think it's been teased out very well.
Thank you, Chairman. Thank you, everyone. Bye-bye. See you soon.
Bye. Okay, in which case, I'd now like to move on to agenda item 7, United Lincolnshire Hospitals NHS Trust COVID-19 update. You can find this on pages 33 to 42 of the agenda pack. And once again, at the end of the presentation, I'll take questions if you can type in the speak box. And I'd like to welcome our presenters, Andrew Morgan, Chief Executive of ULHT, and Simon Evans, Chief Operating Officer for ULHT. I'll hand over to you for about 15 minutes of the presentation and questions at the end. Thank you.
Okay, thank you, Chair. I will start if that's okay, and I probably won't take 15 minutes if that's all right. So I'll just give you a sort of high level, because I was assuming you've read that particular paper. I suppose the issue with papers like that is they're written at a particular moment in time and life moves on. And I think that paper was written 25th of January from memory. So if I give you some more up-to-date figures, hopefully that will help you. So since COVID started nearly a year ago now for our trust, and we're almost coming up to the first year sort of anniversary in the middle of March. So since then, we've had 2,754 COVID positive inpatients, and these are the figures as of yesterday. 1,874 have been discharged home, and sadly 748 patients died. There are some other groupings which I won't go through because they're much more detailed. So if you're trying to get those figures to add up to 2,754, they won't. But they're just the high level figures. In terms of current inpatients, again, if you go back to wave 1, the maximum we got to in wave 1 was 104 COVID inpatients at any one time, and that was back in April. And for wave 2, we reached 253 in early December. Thankfully, numbers have started to go down since then, and the number yesterday was 85 positive inpatients, 56 at Lincoln and 29 at Pilgrim. Nationally, we're of course still in alert level 5 as a country, and the NHS is still at emergency planning level 4, which is the top level escalation. So that's where we're in national command and control by NHS England. So numbers peaked, numbers now starting to decline, which is great news. I think that's mirrored by the sort of incidence level in the county, which I'm sure the Director of Public Health has shared with you as councillors on many occasions recently. We're also seeing our staff absences going down. Again, if I'd been here, as I probably was in mid-December, we would have been talking about staff absences around about the 13-14% figure. Not all COVID related, but probably about half of that absence would have been COVID related. Again, if I look at this week's figures, we are down to about 7% absences, so a much improved position. Hospital's still really busy. Bed occupancy, which is a bit of a rough and ready calculation, is up 90% sort of level. I always express some caution about bed occupancy figures, but I know it's a figure people like to know. We obviously have to make sure we don't mix COVID and non-COVID patients. So it's really important that although we may have an empty bed on occasion, the ability to put the right patient in the right bed does mean sometimes that we do have some vacant beds alongside some patients waiting for a bed. It just happens to be the wrong sort and the wrong mix. But as I say, main hospital's still really busy, particularly busy around intensive care units. That's mirrored across the country. So again, as of yesterday, we had 31 beds open across our sites, and 31 beds were full across our sites. And that included 21 COVID patients in intensive care. And I happened to be at Pilgrim Intensive Care Unit yesterday for an hour or so. These are not all elderly patients who are in intensive care with COVID. So there are some younger patients. And as a man of 58, there are people younger than me in intensive care at the moment. So busy sites, figures going in the right direction. Intensive care, really, really busy. We are having to move staff from around our sites to support intensive care. Again, that's a national position, not just a local one, but it does impact on our ability to run some of our other services. And really, unlike wave one, we have been trying to progress as much as possible with a range of our routine services, care levels in urgent care, A&E, much increased from what they were at wave one. We've been trying to do as many outpatients and elective activity as possible. We've got the green site at Grantham, which I think is your next agenda item, both the temporary arrangements and the post temporary arrangements. I won't wander all over those agenda items. And you'll also see in the report that I've given you the focus that we've had both on staffing numbers, so making sure we have as many staff available as possible. And we have had some success recently on making job offers to over 200 healthcare support workers, as well as making job offers to over 120 overseas recruits. So we are making progress with our recruitment. And we've also listed in that report for our board the details of what we're trying to do to improve staff wellbeing, to keep our colleagues as safe and well as possible. They're clearly working in very difficult and stressful times. So you'll see mention there of PPE, of risk assessments and work adaptations. The vaccination programme has gone well in the trust. I think we've mentioned the various wellbeing offers that we have available, including some fairly simple things such as everyone has a personal thermometer to be able to check their symptoms and make sure before they come into work or when they go home from work that they haven't potentially got COVID symptoms. So I'll stop at that point, Chair, if that's okay, and open it up for general questions before we get into the Grantham items. Thank you.
That's brilliant. Thank you very much, Andrew. First question is Councillor Robin Henshaw.
Thank you, Chairman. Good morning, Andrew. And
Morning.
I have to say thanks for overseeing what has been definitely challenging times for you and the staff. And thanks for a lot of the efforts you're doing to recognise the hard work of the staff and trying to help them along the way, because certainly the staff being at the end of the tether is a real live situation there. I just have two questions, Andrew. One is about the PPE procurement, which there have been some scams prevalent across the country. Have any of them scams manifested themselves in the Lincolnshire supply chain? And the second question is, National Health Service providers have written to the Prime Minister requesting that lockdown is not lifted prematurely, at least because of their concerns at being unable to cope. Is this situation in Lincolnshire, as our Lincolnshire MPs seem to want to open up a free-for-all without proper regard for our NHS? Thank you.
Okay, thank you. Simon might want to chip in on the PPE one. Whilst he's preparing his answer to the specific that you mentioned, I suppose it is interesting when we compare where we are now with wave one, when there was lots of understandable concern about we didn't have supplies for PPE, or it was all a bit sort of last minute at .com. I can't recall the last time a member of staff raised with me any particular concerns about PPE. So when I happen to wander down through stores, or when I'm on wards, or when I talk to staff, and I do ask them about have they got the right kit, and if they didn't have it, would they know what to do? I do get very positive messages back. That's not to say some people don't agree with national policy. Some people don't agree with national policy, but in a level 4 emergency, we are really having to follow national policy about what PPE people actually get, and we are supplying that in accordance with that policy. Now, I'm not aware of any scams or frauds, but Simon will now tell me whether I'm correct or not.
No, the procurement team have done amazing work for us. They're one of those teams that sits in the background, gets very little praise, and clearly have been working incredibly hard to source all the millions of bits of PPE we've had. So no, we haven't been subject to that, thankfully, because of their very proactive work. We did have really quite early in wave one, members of the public who were collecting PPE to support us and collating it and distributing in our hospitals. Unfortunately, some of that wasn't up to specification, and in some cases, some of our members of the public were unfortunately being duped into buying bits of PPE that wasn't up to standard. But we were able to remove that out of circulation and feed back to them to say, please be wary of what you're buying and make sure that you're not hoodwinked in this way. But no, we've been okay in terms of scams at ULHT.
So that was the PPE one. On the second question, I'm not about to get into a criticism of MPs or my representative body. I think NHS providers made four, I think, reasonable points to government when they are deciding their policies about lockdown easing. And those were just about, make sure the incidence level is reduced, make sure that the NHS has the right capacity, conclude the priority groups 1 to 9 vaccinations, and have appropriate mechanisms for dealing with the new variants. I don't think those are at odds with people wanting lockdown to be eased. I think it's a question of timing of when that lockdown easing is, and that is very much a political decision. and I'll leave that to the politicians to decide, if that's all right. Thank you.
Thank you, Andrew. I wasn't trying to put you in a political situation. Clearly, it has ramifications, but it is a serious issue, isn't it?
Yeah, no, it is. Yeah.
But as the people I represent, they want to know, whatever reason it is, that you'll be able to cope. And if there's any risk to that mechanism, then I have to convey that to my residents. So thank you very much for your answer.
Thank you very much.
Thank you, Councillor Kendrick. We've now got Councillor Whittington, please.
Thanks, Mr. Chairman, and thanks, Andrew and Simon, for the report. And again, I'd like to echo the comments I think that Councillor Renshaw just made regarding the staff. And if you could just pass on our very best wishes to all the staff for the tremendous work they're doing. I think it's greatly appreciated. I know my wife had her first vaccination on Sunday and at the Mears in Grantwich Centre, and she said it was a really, really fantastic, incredible operation. She was in and out in 10 minutes. Really, really good. So it seems to, and it's just really good that the numbers are increasing, because obviously it's with increased vaccination that we can then potentially start to think at some point in the next few months of starting to ease lockdown. My first couple of questions, I'm taking a bit of a flyer on this, if you don't mind, because it's within the report, it's within the CEO system overview, and you refer then to the feedback on the acute services review following your meeting, and you also talk about the integrated care system that's also been reviewed. And I don't really want to sort of question you too much about those, but I'm just wondering if you've got any ideas when you'd be able to kind of really formalise those two and make the decisions known a bit more widely, if that's okay. So that's a bit of a flyer, if you know what I mean, Andrew and Simon. So apologies for that, but just interested in that. In terms of obviously you had a winter plan, and it is encouraging to see that the sort of COVID numbers are coming down. I'm just wondering, are you aware of sort of in dealing with the sheer volume of COVID patients, if there has been any adverse impact on any other sorts of services that have been provided, and just if you're happy that the winter plan has worked, it seems to have done at face value. Looking back at, you talked about bed occupancy level of 90%. Do you have any spare capacity within the system? I know the last time I worked in an acute trust, which I have to say, Andrew, is back in the early 1990s. It's quite a long time ago. We did actually it was a Stevenage. We did actually have one kind of half ward that I think it was about 10 or 12 beds that was kind of there, and we could kind of bring it back into use very quickly if it was needed. Just wondering if you have anything similar within the trust. And then going down generally, and again, this is probably another bit of a flyer. In terms of the general comments in the paper on finance, it's really good to see that obviously, you know, been following this, and in the past there were some really sort of quite enormous figures around year-end deficits and problems, and obviously an awful lot of that seems to be sort of just looking at the numbers. I mean, you talk in terms of deficits of a few £1 million in comparison to some deficits from a few years ago that were closing up towards the 80 to 100 million. And I know at the time you introduced quite a large sort of cost-saving schemes, and you were sort of looking at the way you provisioned and provide services. I'm just wondering if the sort of better looking financial position, how much of that is due to the stuff you've done, and also is any of it related to any other extra funding that you've got from government? And I know potentially you might not have done, because if you've managed to turn around the finances to such a great extent over such a short period of time, then it's really due credit to everybody involved in that. Thanks, Mr. Chairman.
Okay, a number of questions there. I'll pick out the ones I want to answer, and then I'll let Simon take the rest. But just to warn Simon, I think he's down for winter plan and probably the capacity and bed occupancy ones. So in terms of the acute services review, I think we have either just submitted or just about to resubmit our pre-consultation business case to NHS England on that. So we would then hope that that will then go to national approval, because it's a scheme that requires national sign-off. I can't give you a date because this has gone on an awful long time already. But I think we've responded to the points that were made to us following our assessment panel, redone some of the detail, and will now resubmit that if it hasn't already just been submitted this week. In terms of integrated care system, obviously the NHS and its partners was going through a particular process whereby everyone needed to be a sort of shadow ICS by the 1st of April. We've been involved with NHS England and Improvement on developing our submission pack, not just about us submitting it, but it also involved colleagues from the County Council and elsewhere. We've now submitted our final pack. Initial feedback is positive, and I would expect that to receive national sign-off either back end of this month or early into March. Obviously, the world's slightly moved on around us following the white paper being published last week. So although we may have a shadow ICS 1st of April, what I think that white paper's looking at, subject to legislation passing, is a different model from April 2022. So we're sort of betwixt and between at the moment. Those particular approaches, but we've got our proposal ready, and I would expect us to be a shadow from the 1st of April. In terms of finance, this is one where I cannot claim that ULHT has solved its underlying financial problem. And I think if you go to page 41 in the pack and look at the first bullet point under section 10 on that, you'll see mention there of planned support from the Lincolnshire system. So although we will be declaring as both a Lincolnshire system a break-even position and ULHT a financial break-even position, that is a break-even against plan, and the plan does have within it a large degree of financial support. So we still have a underlying financial problem of the same scale that we used to have. So that's the sort of 80 million type mark that I think people are used to. So I would be misleading you if I said we've sorted all of that and it's gone away, because it hasn't, and we have got work to do to close that financial gap. Clearly, during a pandemic, there's been a very, very different financial regime that's rolling over a bit into next year, so that the funding mechanisms have slightly skewed how that is presented. But I'm happy to make clear that although we will hit the plan does have considerable financial support behind it. But it is still good that we hit the plan that we were set. And again, ULHT will hit the plan this year. We hit the plan at the end of the last financial year. And if you go back in history, it is fairly unique for this trust to actually hit its financial plan. So we are making progress, but we still have that underlying issue to tackle. I'll stop at that point, Chair, and hand over to Simon around the winter and the capacity plan stuff. Thank you.
Thanks, Andrew. Thank you, Chair. In terms of the winter plan, yes, the winter plan this year was very different. It obviously had to consider not only increasing demands that we normally see over winter, but also how we would balance the likelihood of a further wave of COVID. And we did see that, as you've seen in the report, with 250% of the wave 1 COVID numbers. Now our plans took us through various escalation processes, and as you point out, yes, it dealt with much of the demands that were put onto the organisation. But the question around, has it had an adverse impact on other services? Yes, it absolutely has. And this is, it's not unique to Lincolnshire, this is nationally, and sadly is inevitable in terms of having to redirect substantial proportions of hospital services from elective services, from outpatients for operating, into support our urgent care services, at times significantly increased numbers of beds, and I'll touch on that next, but also, and more so this time, a hugely increased demand on our intensive care units, which, although it's very small in numbers, are very, very heavy in terms of the workforce that's required to increase up to 200% of normal operating capacity. So the impacts that we've seen, we are continue to run through our risk stratification and our harm review processes to make sure that patients that are waiting longer for their outpatients or waiting longer for their operations we're aware of what's happening with those patients, and that we're able to prioritise them. But sadly, inevitably, there will be an impact for people not getting access to their outpatients and to their surgical procedures. That said, what Grantham Green Site model has done for us is create a level of protected capacity that many other trusts have not been able to create. So one of the real benefits of the way that we've approached it is that we've managed to protect, particularly for cancer services over at Grantham, continuous access, for example, to breast cancer surgery, which was a really hugely impacted service in wave 1, which we've managed to protect amongst others in wave 2. In terms of the second question around bed occupancy, it is a very difficult one. It's less about physical estate than it is about the workforce to be able to safely staff increased beds. So whilst we do have this year, we've managed to achieve something we haven't done for a number of years, we've managed to create essentially empty wards, physical empty wards that we can move our wards around in the hospital. And what that's doing is giving us the opportunity to do deep clean systems to make sure that we're able to offer the very highest level of infection prevention and control. Unfortunately, what we can't do is staff those extra wards up and create a significant amount more surge capacity. And there have been times where we have needed that, but unfortunately, we just haven't had the workforce to be able to expand. And that's where we've had to call on other services and bolstering the capacity that we have had in order to make sure that we use the very most of what we've got available. In terms of the overall bed occupancy number, as Andrew said, it is quite misleading. I always put an enormous caveat and disclaimer on bed occupancy this year. It does misrepresent just how high occupancy has been in some areas, because we've had to keep some wards in some areas empty, or at least partly empty, in order to protect patients from COVID and infection prevention and control. This is the same nationally. So you will see nationally that bed occupancy is lower, but organisations have reported very high levels of escalation, and we're no different nationally from those other organisations. So hopefully that answers those two questions satisfactorily for you. But as always, happy to add additional information offline. Thanks.
That's great. Thanks, Andrew. Thanks, Simon. Please make that finance, because obviously it's great you're hitting the plan now, obviously, even though there is a deficit in the plan, because as you said, historically you weren't. So it does show progress, and I guess that's really what we're interested in, seeing progress and good progress. So thanks everybody. Thanks.
Thank you. Okay, before I bring in the next speaker, I've got two more speakers left. I will give you the opportunity if anyone else wishes to speak. will remind you just to keep your questions succinct and concise, please, and try and keep them to about 2. Okay, Councillor Matthews.
Thank you very much, Chair. And can I pass on my thanks to you, Andrew? What I'm going to say will sound mean, but it's not a reflection of the enormous feel-good and well factor there is about the NHS and the work that it's doing. I've received 3 separate concerns from my constituents. They're not about the quality of the service they receive so much as about the communication that might have made that service more understandable, if I could make sense to you. So I've got a man who's quite ill with chest cancer, and apparently he's just got onto chemotherapy services, but he went to hospital A to have his chemotherapy, and when he got there he was told that the blood test that he'd undertaken at Ulht to check that he was in a fit state to receive that chemo showed that he'd got too much cancer in his blood, so he was transported straight away to Lincoln, and he had to stay in overnight and have something done to his blood, and then he returned home, and then he's got to go back to Ulht and have a blood test. What he said was, why couldn't the blood test results have been informed to him at home by telephone or text prior to him driving in a fairly unwell state? Now, I may have got the details wrong, but I think you understand the gist of what I'm saying there. And that's not a... So that's one issue that I'm getting. The other is people saying they don't know what's going on, they're not being spoken to, they can't get information. Now, I'm not trying to add to your woes, because I don't think it will change your frontline service one job. But it is about, have you been giving any thought to having non-medical people running a communication and support campaign to try to iron out some of that aggravation? We've got very, very stoic people here on the East Coast, a huge number of very elderly people. They are bewildered, they are putting up with this, but when it actually hits them like that, they've got to drive to Grantham to be told they can't have their treatment. They've got to go to Lincoln, and they could have just either stayed at home or gone straight to Lincoln. It's bewildering them. I feel mean even saying that, so I'm feeding you back that message more than it's not a complaint. It's to let you know what it's like on the ground here. Thank you.
Okay, I mean, thank you, Councillor. And please don't feel mean at raising legitimate concerns, because they would be concerns of Simon and myself as well. We certainly don't want people with compromised immune systems travelling when they don't need to be travelling. And I'm happy to look into the detail of that instance if you want to email it to me, because I'd need to understand more as to what did we know, when did we know it, and what could we have done for that particular patient. But certainly communication is a constant theme, probably in most hospitals, including ours as well, about getting the logistics right, getting transport right, getting the right services in the right place for patients. And we certainly don't want to inconvenience people to the extent that you have just raised. So no apologies needed. Happy to look into it so that if there are lessons or services we can change, we can avoid other people being put in that position as well. I don't know if Simon wanted to add anything to that.
No, thank you for raising it, and always happy to look into these areas, and please don't apologise. We are doing lots of relatively short notice changes in pathways at the moment, or escalations in pathways, and some of that sadly is unavoidable because of particularly around the extent of the capacity that we've got in our intensive care units, and from one day to the next we're having to make assessments about what we can do in our hospitals and what we can't do, and that we realise that's incredibly difficult for patients who will not know necessarily tomorrow what they might be doing, even though they may have had that appointment for some time, and that's also consuming a lot of our time in communications as well. We have bolstered the number of people who are making those calls and the times that we're doing them, but by the sounds of it, clearly there's more that we can do in some circumstances, which we're happy to look into and put more into. And as we come out and we restore more services and recovery, it will get better, and we will be able to do things in a much more planned way. We'll be able to give people more notification, and we'll also open up more access across our hospitals as the level of COVID reduces, vaccinations increase, and we can go back to more of a normal pre-COVID world. But happy to pick up those specifics and work through them for you.
Thank you very much. It was, I will forward you the case for the individual, but it was much more the general case that here on the East Coast, we haven't got frontline services, so everything involves travel. With an elderly population who are quite anxious, and that's just feeding in. I'm sure you're absolutely full aware, but that's the groundswell that they wish they knew what was going on more. But thank you. I will send you the details of the case, and thank you for a very clear answer. Thank you, Chair.
Thank you, Councillor Matthews. I have Councillor Woodliff next, please.
Thank you, Chairman. I'll just see if I can get my camera up. Once it come up. Yes, good. Okay. Thank you, Chairman. Good morning, Mr. Morgan. I've got two questions, which essentially could be one. Which of the four main mutations are dominant in Lincolnshire? And is there any evidence of a third wave on the way? Because, of course, last time when we came through the summer, I think people rather felt that it was all over and done with by September, and then, of course, it all took off again. So we know this virus is mutating, and I believe there are 4 variations in the UK. Which of the 4 is dominant in Lincolnshire? And is there any evidence of a third wave on the way? Because if there is a third wave coming along, well, we need to know about it and act quickly. So over to you.
Okay,
yes?
I think Simon wants to jump in first. I might have said this could be a question for your Director of Public Health rather than your acute hospital chief exec. But between us, I'm sure we can give an answer. But Simon's messaged me to say he'd like to have first to go.
Yeah, so absolutely. We work very closely with our Director of Public Health colleagues, Derek and his team, and certainly, and our pathology laboratories spend a lot of time looking at that. The majority of what we're seeing in Lincolnshire is the Kent variant, and that was the information I got last week. Obviously, things can change, but most of what we're seeing there is that variation that's come through. In terms of the third wave, we aren't necessarily seeing that in our hospitals a third wave. What we are seeing is a very slow reduction of the second wave, much slower than the first, and particularly in our intensive care units. And this second wave has hit intensive care much more than the normal hospitalised patients. So those patients who have ended up being ventilated, albeit there's an important caveat there, is that some of the role that we've been playing in Lincolnshire has been to support Nottinghamshire and even as far as West Midlands, who have been overwhelmed in terms of their ability to respond, particularly on intensive care. So we do have a proportion of patients in our hospitals who have had to be transferred from other regions in order to make sure that they get access to these life-saving treatments.
That's very, very good. Thank you very much. That's very, very good indeed to hear that we're actually taking part in a national campaign to support other areas. I think that's very, very important. So that's very, very good. May I ask a second question, Chairman?
You may.
Yes. Well, firstly, it's to say that I'm very pleased with the service provided by EMAS and by the Pilgrim Hospital. My wife required an emergency operation about a fortnight ago, and EMAS was excellent, and the service provided by the staff at Pilgrim Hospital was excellent too. So I'm very, very pleased to say that. I've just asked my wife whether it's okay if I mention it, and she says, yes, that's fine. So we have that on record, that we offer our thanks to the staff at Pilgrim for all they did. There's only one minor issue, I suppose I'd say, is that on collecting her from the hospital and walking her to the car, I had to shall we say, cross the minefield of the car park. There's something about Pilgrim Hospital, its pathways and its car park, which remain a considerable hazard. And seeing as my wife had dislocated her hip, you can imagine how concerned I was about having to negotiate the holes and all the rest of it in all the in the car park itself. So I think that looking at the financial side of things here, and the fact we do pay for the car park there, it's about time somebody filled in those potholes and straightened out the pavements and made access to the hospital much, much safer. Otherwise, there could be a few accidents in the hospital car park, and that'd be rather unfortunate, wouldn't it? One doesn't really want to have those type of things. So maybe a significant program is required to improve the health and safety of people who visit Pilgrim Hospital. And that's really what I want to say. Okay. Thank you very much, Chairman.
Thank you. I'll start and then I'll hand over to Simon. I'm delighted that you've got a great service from EMAS and our own trust. I obviously can't take the credit for EMAS. I will pass it on to Richard when I see him next. And please do pass on our good wishes to your good lady. I hope she makes a fantastic recovery. I will hand over the estates bit to Simon, but just so people know the context, when we appointed Simon to the coup role, I did give him what I call a hospital pass by moving the estates and facilities functions into his control as well. So he's taken it on relatively recently, but of course anything that is now wrong with our estates and facilities is now his fault. So I will pass on to him to talk about car parks because I know he's well versed in it. Thank you.
Thank you.
Thanks for that, Andrew. And it's great to hear the outcome for your wife, Councillor Woodliff. So great, thank you. In terms of car parking, yes, it remains a big issue for us. It's not just at Pilgrim, it's across all our sites. It's an area that hasn't had significant investment over the years, and I'm pleased to say we do have an investment proposal. We did have one for this year that would have already played in, but we've had to prioritise some other elements during COVID, as I'm sure you could expect. Things like expanding our ICU capacity and various other things have had to go in, sadly, above the list. But that said, we're going to do some minor elements of potholes and various other things over the course of the next couple of months. But we are looking at a much more substantial response to this next year if we can, recognising that at times our parking is insufficient anyway. So we are looking at the potential of decking systems in order to create perhaps just one more story and a purpose-built modular unit, which will do away with much of the issue that we've got around the quality of the surfaces, but also give people safe, well-maintained access as part of that. So we have some short-term bits, but we realise that's not moved fast enough. But we're also working on this next financial year, some more substantial things to deal with this for years to come.
Well, thank you very much indeed for your answer. I appreciate the situation. It is difficult, and we live in difficult times. But obviously, the car park and the access to the hospital is very important, particularly for anybody who has poor eyesight. That is something we have to be concerned about. As for my wife, I am very, very grateful to the services provided by Ulht, the staff at Pilgrim Hospital, who did a brilliant job, and particularly the staff at EMAS, who helped us out of a very difficult situation. So my thanks to them, and I will write and put it formally down, okay? Thank you very much indeed. Thank you, Chairman.
Thank you, Councillor Woodliff. I have no further speakers, so I just have two questions myself. And that is, firstly, how is staff morale?
Mixed, I would say. I think I mentioned at the start that we are almost a year into this. It's been a really difficult year for our colleagues, coupled with people will have their own private life issues as well, with partners being furloughed or losing jobs, not being able to see families, etc. But just focusing on the work issues, we've had some really difficult decisions that we've had to take during the year. We've redeployed people, we've moved people between sites. On occasion, we've had to cancel people's annual leave. So I would say we're doing everything we can around morale, but it has been one of the most challenging years I think this trust will have faced. And I think that shows through in our staff survey results. We've got a lot more to do with our staff side to improve that. What I would say is our relationship with our unions, with our staff side representatives, are probably as good as they have ever been. The regularity of meetings, Simon has, I think, virtually daily updates with the staff side chair about operational matters. They work with us on solutions. We don't just hand them information about what we've done, but I think we've got a lot more we need to be doing. And that's why I think in terms of some of the other questions and answers we've given, avoiding a wave 3, getting the country safely out of lockdown such that we don't have a sort of boom and bust approach, and our colleagues being able to take their annual leave, including the leave we've allowed them to carry forward into next year. People need to be able to have a proper rest and recovery before we get fully into the sort of restoration and recovery phase. So a bit of a long answer, Chair, but difficult would be the one word answer.
Yeah, no, thank you for that. And very finally, what percentage of the ULHT staff have now been vaccinated?
Okay, as of I think yesterday's figures, it was just under 90% of the staff. If you look at those that we consider to be at risk, it's over 95%. And if you look at our BAME colleagues, it's about 84-85% from memory.
Excellent. No, that's fantastic. In which case, then, I'd like to move to the proposal. And the proposal is to note the information presented by United Lincolnshire Hospital NHS Trust as part of its update on its response to COVID-19 pandemic. To consider the timing of the committee's next update from United Lincolnshire Hospital Trust, which I would recommend we just put into the work programme for the new council year. And finally, to thank all of the ULHT staff for their effort in response to COVID-19 and to ensure that our comments are made through to them at this time where they are under considerable pressure and doing a superb job. So that's my proposal. Do I have a seconder?
Happy to second that, Chairman.
Thank you, Councillor Brewis. In which case, I'll take it by dissent. If there is any dissent, please can you indicate in the chat function now? No, in which case we'll take that as carried and a confirmed decision. So thank you. I'd like to move on now to agenda item 8, the Grantham Green site arrangements second quarterly review, which can be found on pages 43 to 92 of the agenda pack. And once again, I'd like to welcome our presenters, Andrew Morgan and Simon Evans, and again hand over to you for the presentation.
Okay, I usually hand over to Simon for the Grantham items. Bear in mind you've got 2 reports here. The first is the second quarterly review of the Grantham Green site arrangements. If you remember when we signed this off back in June last year, we did give a promise that we would do quarterly reviews. We've honoured that promise. So you have here the quarterly review up to the end of December, which went to the first available board on the 2nd of February. You've also got a second supplementary paper there about the Grantham temporary arrangements. Bear in mind we're approaching the end of March and that the board signed off temporary arrangements until the end of March. You've got an update paper there about the process between now and the end of March. But I'll let Simon run through those papers for you. Thank you.
Thank you, Andrew, and thank you, Chair. I won't go through what is actually a very detailed report in terms of the quarterly review, other than just to pick up perhaps some of the significant points that were discussed at the ULHT board. The first paper then, as Andrew's described, is the second in the quarterly reports, and actually added a number of elements that were recommendations from the initial quarterly report that was prepared last year. As part of the review, we look back at the key criteria of what we wanted to do that was set out in the Grantham model in the context of what we've faced during that time period. And I won't rehearse the 250% increase in COVID patients, but to say that the three primary aims were around creating a response to hosting patients and treating patients in an environment that offered the greatest level of infection prevention and control possible, to deliver treatments at a level and at a scale that would be reasonable given the pressures that we were seeing across the NHS, but to target particular high-risk groups, those patients with suspected cancer and clinically urgent, and to be able to treat them in a timely way. And also, and fundamentally, and this goes back to my earlier point, is to be able to do that with some resilience, so that if we did see substantially increased numbers of patients who are becoming COVID positive and were hospitalised, that we would be able to maintain this service and that we wouldn't have to shut it down because of outbreaks or other such very difficult or unfortunate events. And I'm pleased to say on those three aims, this quarterly review confirms that we have managed to achieve what we set out in the first place. In particular, I think it's worth noting the thousands of patients that we've now been able to treat where they haven't contracted COVID in our hospitals. And one of the biggest concerns that drove this particular response was the research nationally and internationally that said if you contracted COVID and you went through a general anaesthetic procedure, the chances of your survival are significantly impacted. And I'm pleased to say that no patient during this entire time contracted COVID, went through a general anaesthetic process and came to harm. In fact, no patient contracted COVID or was COVID positive on our surgical pathways throughout this whole time, which is a substantial achievement and reflects the enormous efforts of the teams over there, who were increasingly more and more vigilant, particularly as the second variant has presented and its increased level of its transmission rate, and have managed to protect those very vulnerable patients. A couple of other important elements, and then perhaps open to questions then around the report, is that it reviewed whether the circumstances are sufficiently different now, or whether any of the override criteria that was specified in the previous report would mean that we would need to change this model immediately or before the end of March. And the recommendation that was accepted at the ULHT board is that there isn't sufficient grounds to suggest that we would need to change this. In fact, it's actually been reinforced by the level 5 COVID alert, the level 4 emergency response in the NHS, and our own experience in Lincolnshire with substantially increased levels of COVID across the region, and the need to protect those patients who are vulnerable on those treatment pathways. So that was reviewed and proposed and accepted by the ULHT board. But very deliberately in this quarterly review, we didn't approach the decision of what happens at the end of March, and that was put into the second report, which we'll touch on next. So I think that's it in terms of sort of summary, drawing points to areas that had particular focus at ULHT board, and happy to answer questions on the quarterly report. Thank you.
Okay, thank you both. First of all, I'd like to bring in Councillor Wootton, please.
Yes, thank you very much indeed, Mr. Chairman. I've got a number of questions, Simon, for you. First of all, we start at page 63, 64, and look at the outpatients units, which particularly in Gonby Road are being well used. In fact, hundreds of people are going there using those services. And then I'll go back to page 90, talking about the second report, the recommendations that they are only there for another 3 months, and that includes the theatres at Grantham Hospital. Are you saying that those theatres are only temporary and not permanent? Because that's the understanding that I had, that they were permanent. And the second question is relating to the UTC. You talk in your report about 1,000 or 5.12% being referred to A&E, which relates to 1,024. Now, I had to go to A&E with my wife last week, and I was horrified to find 10 o'clock in the evening on a Wednesday, 60 people were waiting to be seen. And then I see on the Fighting for Grantham Hospital Facebook page that patients are saying that they waited from 7 o'clock at night to 7 in the morning to be seen. How can that be right? Surely these patients should be seen back at Grantham. And I look forward to your report in the future to see why you will not revert back Grantham to its former A&E site. Thank you, Chairman.
So thank you for those questions, Councillor Wharton. In terms of sort of drifting onto the second paper a little bit, but absolutely the numbers that we've managed to see at Gonby Road have substantially increased. We've invested a significant amount into the Gonby Road site in order to improve the quality, and we're really pleased with the feedback we're getting from patients about the environment there. The initial, we would like to maintain this capacity for a further 3 months, is essentially a holding position. It's not saying that we expect to close that in 3 months after Q1. What it does is gives us time to do a full assessment. Much of the second paper that I've not yet gone through, but it talks about the need to do a scientific assessment of what the risk factors are and what are they likely to be in April going forward, because they're clearly going to be very different to June of last year. And therefore, for us to make the decision again, we need to understand that full spectrum. There are no plans currently to close Gonby Road or to move the theatres away, but nor are there plans to keep them forever and more. So it is just that position to hold them. What we have said is that part of our recovery approach, the likelihood is we will still need social distancing to be a firm part of our clinical model. And for that, we're likely to need a lot more space to be able to treat people. Now, there are different ways we can run our clinics, and there are different ways we can run our theatres. But ultimately, that might mean we need more physical estate and the ability to do that. Again, we need to do that assessment as to say whether we can and need to sustain all of the sites that we've currently got running, and whether we continue to run the types of specialties that are there. And that will be in our subsequent review that we'll look at in March. In terms of urgent care, the UTC, yes, there are a proportion of patients that go over to Lincoln and Pilgrim. There are a number of patients who always did go to Lincoln and Pilgrim, and I won't ask questions about particular criteria, your personal circumstances, but there are pathways which always have to go to Lincoln because of the specialist services that are offered there. And any future model will need to consider that maintaining. That said, we have had particularly difficult times at Lincoln and Pilgrim hospitals with urgent care, and we have had long waits, as we've seen in previous years. Now, we have significantly reduced many of our waits. Our ambulance handover delays, as an example, are 70% reduced from this time last year. So we have managed to achieve some really very positive improvements, but we do know that at times our departments are overcrowded, and although 60 does sound like a large number, it is too many for that department. That's down from 80 and 90 patients that we were seeing in similar circumstances last year. But nevertheless, we accept it's not acceptable. We are still continuing to improve our flow through hospitals and the discharge rates and the way that we speed up that urgent care pathway. And in particular, the quote around 7 to 7, where of our patients, more patients now are seen and assessed within 15 minutes than they have ever been in the history of the Trust. And that 15-minute triage is not necessarily treatment started, but it is a very important safety indicator. And we share that data with our regulators and Care Quality Commission regularly. And in addition to that, we've also made substantial improvements on the number of patients we do start treatment within that 60-minute window, but we still recognise there's more to do. What we do find is that once people have started their treatment, they've been seen, if they require admission, they will wait for substantial lengths of times when we're under extreme pressure. And I imagine that that is a particular aspect of the care that you have seen and colleagues will have fed back to you. And that's all part of absolutely our urgent care improvement programme that we're playing in as we come out of winter, to make sure that once the difficulties of COVID segregation are relaxed, we're back on to our improvement journey and making that a better pathway for patients.
Chairman, if I could come back, please.
You may indeed.
Thank you, Chairman. I fully support your proposal to keep Grantham as a green site. I mean, we've seen so many more people being treated for cancer patients, and also the fact that UTC has run well, because 87% in your report said that they chose Grantham because it was the nearest location. But what concerns me is those 1,024 people who are being referred to A&E. Surely that gives a case for Grantham to be returned to a proper A&E service instead of having to go elsewhere.
So the measures that we've put in place, I'll kind of restate, these were temporary measures. These are what we've talked about in these papers, and as the Trust, the changes that we've put in place are absolutely time limited and specific to COVID. Obviously, there is the ASR work happening in the background, but these reports deliberately make a very specific reference to the temporary changes that we've made. And as such, and you will see in the second paper again, we are now starting the plans to put in place the necessary staffing, processes, procedures to return the UTC at Grantham to its previous A&E model. So that if we do make that decision in March, and that's the right thing to do from public health perspective, and the science and everything supports that, we can do that in a timely way. So in terms of that response, what I can't say is that as it currently stands, that would not, in terms of these recommendations, that would not be the best thing to do on the whole, which is why we put this model in terms of the temporary measure. But going forward, we would anticipate at some point that we put back in place the model that was pre-COVID.
Thank you. Thank you, Chairman.
Thank you. I'd just like to build on with Councillor Wootton's question, and that is, if you do take the decision to revert back to the pre-COVID-19 model in April, that what is actually the extension time on this? Because you're going to extend it possibly by an additional 3 months, which will make it a full 12 months. Does that still make it temporary, or are we in a very similar position to before, that temporary becomes permanent through a level of time?
I think what the report is describing, that at the end of March, the reason, the second report, not this quarterly review, but the second document describes the reason we're taking the measures to plan actively for reverting back is there's an anticipation that that would happen in the month of April. And that there wouldn't be a further 3-month extension. Now, this is all hypothetical still, because it's subject to the report and subject to the board's decision at that point of whether that's the safe thing to do. But the extension that's described in one of the recommendations is actually about increasing capacity. So Gornaby Road the theatres, all of those additional measures that we put in place, which actually offer greater level of access. It's not a change for patients, it's an increase in the offer of service. They are recommended to extend for a further 3 months, but we don't necessarily perceive that as a substantial change to patients' pathway. It just means more people will be able to be treated.
Andrew, you want something?
Yes, thank you, Chair. I suppose we're being slightly hampered at the moment. We veered off into the second paper that Simon hasn't actually presented, but that's fine. But just to be clear on the reversion bit, and it is actually recommendation 4 in the second paper, so page 90 of your pack. The board was very clear back in June that these were temporary arrangements up until the end of March. And at the board on the 2nd of February, we reiterated that point. I remember personally reiterating it, and I think Councillor Wootton may have even tweeted the comments that I made. The presumption of the board is that we revert back to the position before we made the decision, so back to the June 20 position. So that's a clear desire. That's why recommendation 4 says, subject to recommendation 1, which is that extra bit of research, we will revert back. That's why Simon's team are now working really hard on all of the rotas and the workforce plans, working on it now, on the basis that if the board says on the 16th of March, which is when we will be considering this, that yes, we should revert back, Simon and his colleagues then have a remaining 2 weeks or so to get the old model, if I can call it that, back into place. So we haven't said this will go into June. There is a presumption of reversion, and that's the planning that we're doing at the moment. Thank you.
Okay, thank you. In which case we'll move on to Councillor Whittington, please.
Yeah, thank you. Thanks, Mr. Chairman. Thanks, Andrew and Simon. I'll make a few comments first on the green site. And actually, when you said that no patient had contracted COVID whilst at the Grantham Green site, I would kind of put on my paper, wow, because this is incredible, because that is an amazing achievement. And I think it really does prove, I think, that just how thorough everybody and the staff have been there to actually ensure that the site at Grantham does remain COVID free. And actually, if you look at the RAG ratings, the majority are green, just one amber. And I think sort of the comments that Councillor Wootton have made really has certainly meant that cancer patients in the county have still been able to receive the level of care that they actually need, which I think is fantastic news. So I think for the residents of Lincolnshire, the green site looks like it's been a real success, for those patients with cancer. I'll make a few comments on potentially what the green site has done for the residents of Grantham, and obviously on the outpatient performance. That's one of those, and it looks like it's been really, really successful with lots of patients being treated. I used the Gunnerby Road Clinic at the end of November. I think I mentioned it previously, for an orthotics appointment, and I found this level of service I received was excellent. And a week or so ago, I received a phone call from the team there to say that my foot implants had arrived. And I was given two options, either to go pop in and pick them up, or they'd be quite willing to post them over to me. So I took to the postal option. They arrived yesterday. So the service I received was actually first rate. So if you just pass on my personal thanks there, it obviously just seems to be a really, really good. So I'm really pleased with that. And I'm pleased that the satisfaction levels certainly seem to be good, apart from Grantham Health Centre, where the satisfaction rate only seems to be 38.3%. I'm just wondering if either Andrew or Simon could just give us a bit of context as to why you think that's so low, when the other patient satisfaction for the rest of the service in Grantham seems to be a lot more positive than that. Really pleased that you've sort of got a dedicated patient transport provider in place as well. So just if you could just a few comments on how you think that's working. I've got a bit of a slight problem because in one of the reports, the first report, it says that one of the recommendations seems to indicate that you've agreed for the green site to stay until October 2021. And the second paper about Grantham seems to think that potentially any extensions may only be for 3 months. And I'm just wondering, am I misreading something? Because if you're potentially going to maintain the green side of Grantham until 2020, until October 2021, I thought you maybe need to provide the other services, sort of the backfill services until then. So it's probably me just misreading the papers. So if you could just clarify that, I think that would be really useful. And hospital passes, yeah, I played rugby for many years, and I took a heck of a lot of hospital passes during my time playing, and also received some as well. So this is a bit of a hospital pass, and against a bit of a flyer. And I know you've probably already kind of mentioned it and referred to it in the question, in the answer to Councillor Wootton. It's just really to just some indication of when you think potentially the residents of Grantham might go back to sort of the post-green site situation, because I do pick up a lot of comments from people, that they accept the temporary arrangements to a large extent, but I think they just want clarity finally about what's going to happen regarding Grantham. Thanks. Thank you. Thanks.
Okay, shall I to pick up that last question, I think it might have been my last answer. The presumption is that the temporary arrangements don't carry on beyond the end of March. What we have got to then work up is what that model then looks like, but it would be about putting the A&E back in to the position it was before we took our decision back in June, and that's what Simon and his colleagues are working on. The October 21 bit, I think, is probably a reference to a misprint on the top of page 79 in your pack, where it says approval was granted by Trust Board to continue green site model in October 21. I think that's a reference to October 20, when we took the first quarter review and we agreed to it carrying on during 2021. So apologies if we've thrown you with that.
I
reference.
I kind of read that and I thought, how does the rest of the paper back that up? Thanks for clarifying that. Thank you.
So that was that should say October 20, that we'd carry it on till the end of March with a very clear presumption, and I think Elaine, our chair, did make this point at the February board, a very clear presumption that these were temporary and we would revert back, subject to the other recommendations about continuing the Gonaby Road and the other arrangements for at least 3 months. And it does say at least in that particular recommendation. I'll just find which recommendation that was. Recommendation number 3 in the second paper. And I presume, Chair, we now are wandering over both papers as opposed to just the first one.
It's inevitable, to be honest with you.
That's fine. We'll just take that as a given. I think Simon might be poised to step in and sweep up the ones I haven't answered. Thanks.
Thank you, Andrew. Chair. In terms of the Gonaby Road, it's great to hear it's still doing what it should. The health centre feedback, so it's not worded terribly well in the report, so apologies for that. The distinction between satisfaction and dissatisfaction. So the satisfaction levels are kind of the net promoters, that essentially people very, very positive about the organisation, about that particular environment, and some score higher than others, and the health centre didn't have as high as the others. And the level of dissatisfaction was actually extremely low, so that's positive. But clearly, the health centre didn't win as many hearts and minds as Gonaby Road did, as an example. And now I think there's 2 elements behind that. The firstly is that there is a limited service at the health centre in terms of women's and children's services. and not the full range of services there used to be at the Kingfisher unit on the Grantham side. And it may be that because that environment was better, it had a more comprehensive suite of services, you didn't have to return or use other services, that didn't trigger a sort of satisfaction level. The second one is that in terms of it's a shared facility with lots of other services as well, which sometimes will make it feel certainly more crowded than some of our other facilities where we've got more far less people going through and far bigger estate. So those two things we think are probably part of that. And of course, as we are with all the other elements of the Grantham Green site, Women's and Children's Services at the Health Centre are one of those functions that we're looking at the restoration back to the Grantham site as part of that active planning that we've talked about in recommendation 4. And then absolutely apologies about the October timescale. That's misleading. It's most definitely March, and hopefully that answers all your questions there.
Thank you. In which case, I have Dr. Wookie next, please.
Thank you, Chairman. Just 2 questions. One relates to Grantham. There are clearly members of the committee who are much more involved in the details of Grantham. I don't intend to even suggest that we've made any decision in Health Watch as to what the future should be. But there are a lot of statistics on pages 67 to 70 of our document. I'm not sure what the numbers on your document are, but relating to the UTC and the previous A&E figures for 2019. And I think to get a rational comparison at some stage during the next 12 months or whenever it is, they need to be specified as to what you're comparing with and with what. I mean, the Grantham's A&E situation has changed a lot from, I can remember when it was a full A&E, but for many years, after about 2010, there was a long list of patient conditions which were not treated there. So it was a sort of, if you like, an A&E with special specifications. Then you had different times when it was open at night and when it wasn't open at night. The result is that I think it's very difficult to compare what has been going on with the UTC and what's been going on previously. And so I think when you come to get some more statistics together, and I understand obviously at the moment you've got so many other things on your hands, then it would be very useful, particularly since we inevitably at Health Watch are trying to provide signposting to people as to where they can find information when they need it. And the other thing just related to that, which I have made at Health Scrutiny before, is the matter of terminology, because both the words ED and A&E are both mentioned in your document, and the poor old public really are very confused about what all the names and nomenclature of urgent and emergency care is. And somebody at some level, whether it be in Whitehall or Midlands or East Midlands or in Lincolnshire, needs to actually decide whether or not the word A&E is going to be used in the future or not. I think it's probably such engraved in our psyche, it's going to be quite difficult to get rid of. But an ED is obviously, I think we're beginning to know what an ED is, but A&E is a bit of a generic term and it does cause confusion. My second query was regarding COVID occurring in patients away from Grantham at Lincoln and Boston, both in their green zones or in their A&E, now I'm using it, their emergency departments as well. And whether you've got any figures for that. We've had a bit of feedback from some people who have been admitted with an acute emergency, and have developed COVID within a few days of admission to hospital, which can be a very tragic state of affairs for elderly people who may have fastidiously kept themselves apart from everybody for nearly 12 months, and then within a week they've developed COVID in hospital. So just some figures and your impressions of that would be very useful as well, which I will take back.
Thank you for that, Dr. Wilkie, and those, as always, great questions from colleagues. The comparison of numbers for 2019-2020 was quite a deliberate model. The reason being is all the things that you raised. This report wasn't necessarily going to go into, the subsequent changes of Grantham's department. And what we wanted to do was deliberately compare the pre-COVID model and processes to the post-COVID, not any historical models that predate that. So we did very much want to compare it to the sort of standard operating model of reduced hours A&E as it's been described. ED and A&E, I completely agree. I look forward to the day when we're able to describe it in the way that our professional groups wish to describe it, which is emergency departments and UTCs. But as you say, it is confusing. Many people know them as A&Es, and we are struggling to lose that terminology. So apologies, it's used interchangeably in future reports. So I will make a note of putting in a glossary which helps explain any differences between UTC, A&E, EDs to make it more approachable. In terms of COVID patients in the green zone and ED, it's remiss of me. On my last answers, I should have stipulated. Councillor Whittington made the statement that no patient in Grantham at all, I think in its broadest sense. And I did caveat slightly when I described it, is that no patient on any of our surgical pathways or any of our high-risk treatment pathways contracted COVID. We have had one patient at Grantham Hospital when we restarted our recovery and rehabilitation ward, when we put that in place last year. A patient did contract COVID and likely in transfer from one site to another. They were isolated, but they weren't a part of any of our green side surgical. So we were able to protect all of those most vulnerable patients. And in that mind, in terms of your question around our emergency departments, yes, it's an extraordinarily difficult thing to be able to separate patients who may be vulnerable from patients who are suspected or likely to have COVID. One of the reasons why our emergency departments are so difficult to manage at the moment is we've essentially split them in two. So both Lincoln and Pilgrim Hospital emergency departments now have a suspected or likely COVID part of the department, and then a not suspected, in order to try and protect those patients that you've described who are vulnerable, who may not be displaying those symptoms. Unfortunately, we know that some patients are asymptomatic, and that doesn't protect patients from those groups. So we still try to enforce our social distancing and all the other PPE measures, including asking our patients to wear PPE where it's appropriate. But we still do have patients who are likely to have contracted it either within the emergency department or on transfer into hospital or in our assessment units whilst we're testing and essentially confirming their COVID status. And unfortunately, none of our tests are perfect, although the PCR tests that we do use are very accurate, but that still has a turnaround time which has been up to more than 16 hours. So we still have that potential time window where patients are not confirmed as COVID or none, and they may still also be incubating and therefore not trigger a positive test result. And for that reason, we still have nosocomial transmission between our patients, and in some cases, historically, possibly between our staff and our patients, although the measures that we put in place for our staff are certainly much more robust than they were in wave one. So that still does continue. It's a major risk for us that we monitor on a daily basis. I'm pleased to say our nosocomial rates now are significantly reduced and are amongst certainly the lowest across the region at the moment.
Thank you very much. Just one, do you have any figures as to what the numbers are of patients contracting COVID whilst in hospital or when they're going through the processes that you've mentioned? And do you actually now have COVID wards and non-COVID wards amongst the general admission population?
So I can give you a figure shortly as it loads up on my system in terms of the live position. I can't split that down to a specific departmental level, so I can only say what it is at a trust level, partly because patients move through different departments and it would be a near impossible feat. In terms of separating, yes, for nearly 12 months now, we have had COVID positive wards, wards that are suspected COVID, wards that have patients who have come into contact with other patients who are positive but are not themselves. And that is, as I mentioned earlier, one of the reasons why it's so very difficult to use bed occupancy as a reasonable figure now, because some of those cohorts will restrict patients from being able to be admitted. You can't put a known COVID positive patient into a ward that is known as COVID negative exclusively. So that is an example. But yes, and we continue to operate in that way.
Thank you very much. Thanks.
Thank you. I have Councillor Cabery Brown left, and then I have a few questions myself, and I'll be closing down the debate. Councillor Cabery Brown, please.
I'm going to unmute myself, that's right. Firstly, Chairman, thank you very much for letting me speak. But I'd like to thank the officers, Simon and Andrew, very much indeed for the way in which they've conducted this survey and all the answers to the various questions we're getting this morning. I have got a question. It may not be, they may not be able to answer it, and they may not possibly be allowed to answer it. I don't know on this. I have been fighting for reinstatement of Grantham A&E as such. Right from the first, I would still like a definition of the word temporary, because it was used at least 6 years ago to my, as far as I'm concerned, and I thought temporary was something that was no longer than possibly 6 weeks. But the definition from the health service changes virtually as the wind changes. So I would like a definition of what the word temporary, as per the encyclopedias and dictionaries go, and how it is that we have to have different versions of it, e.g. going on 6 years. The other thing I would like to ask is, or to say, since we've gone green at Grantham, I think everybody that has anything to do with the health service have agreed that it's been a very good result, in actual fact. I know people have had to travel further for cancer treatment, but as Dr. Wookie's just said, and various other people, very few people have nobody has caught COVID while they've been in that particular part of Grantham Hospital, or were even allowed in. So I thank the health service for that. I would also like to ask, first of all, I wish to reiterate, and I would like them to confirm it, that we definitely do have a ward in Grantham Hospital that can be accessed 24/7. A colleague of mine recently had a problem within the 24-hour limit. It was about 3 in the morning. She insisted on going to Grantham She went into what I thought was called Kingfisher ward at one time. Anyway, she was allowed in. She did go in. She had absolute tip-top treatment. Now, this was the middle of the night. There were 2 different doctors available, and she felt very well cared for. So if we've got that service, why is the health service looking at the costing, or I would like to know, how much did it cost to put the whole of the A&E unit into a green area? It must have cost quite a bit because you moved loads of people out, and surgeons and various operating theatres were moved. If you've paid all that out and you're only going to keep it there for 6 months, a year or whatever, how is it? Would they not consider we're really wasting the money? Either we go back to having an A&E or we keep it green and we advertise better that we've got this ward that is available for casualties and not send them up to Lincoln, where someone today said they were waiting 12 hours. This doesn't make sense to me, Mr. Chairman, and I would like some sense putting on it. I'd like to know how much the cost is for starters, for keep changing around like this, let alone putting the public at, as they consider in Grantham, and we all do, at risk, because we need a 24-hour service. But I want to know, have we definitely got one? And why isn't it being advertised more? And why aren't ambulance drivers being told to take people to Grantham instead of the wait at Lincoln? Thanks very much. Probably too much to ask, but for those answers. Thank you very much, Mr. Chairman.
I'm sure that our colleagues can try and answer some of these, though I do think it cuts across to the CCG and also onto LCHS as well, to be fair. So, but if you can try and answer, thank you.
Yeah, shall I have first dibs, as it were, at some of those? I don't think there's an NHS definition of temporary, if that was the first question that you asked. I would absolutely say that the acute services review, which is the process we want to go through to get a definitive answer to the questions, has taken far too long, and I think has brought the whole NHS planning into disrepute on occasion, bearing in mind how long that's taken. So I've been clear since being at this trust that the arrangements we've put in place since June 20 at Grantham have been temporary. And we've talked a moment ago about the decisions we need to take to revert back, subject to that being safe and appropriate. But the presumption is we do end those temporary arrangements after 9 months or so and go back to what we had. In terms of the cost of the green site, I'm trying to now remember some of the earlier board papers and whether we put any costs in those. And Simon was often the author of those reports, so he's probably now going to have a quick look to see if we did put those in. But I do just need to take people back to the 2 quarterly reviews that we've had of the green site, and people may be able to say, well, you shouldn't have done that because you had a cost. But let's be really clear. Through the green site, we have significantly reduced harm to many, many thousands of patients, and I'm sure have saved the lives of a number of patients, including those who require cancer care. So I think we've heard the green site has been a success, and I think some of your colleagues on this committee have confirmed that today. And I'm certainly not suggesting you said anything counter to that, but there will have been a cost to that. There's been a cost of setting up Gonaby. There's been a cost of putting in place those new theatres that we've got. There are a range of costs, including setting up a 24/7 UTC, which is what is currently there. So those are the bits I jotted down. I don't know, Simon, if I've missed most of the questions or bits you'd want to add. What have I missed?
So the costs associated with all of the response, and I'm afraid I can't drill down to just purely Grantham on this, because it also included other changes at Louth and Lincoln and Pilgrim. But in terms of creating this model of care, we've invested £1.6 million in terms of the changes, and that will include Gonnaby Road and other elements as part of that. And I think but I agree, Andrew, it is very difficult to unpick the elements of what is very specific to this and what would be the things that we would need to do anyway in a response to this kind of emergency and international crisis, essentially. Because if we didn't do some of these things in Grantham the way that we did, we would have needed to have done them somewhere in order to save lives and prevent harm. That's perhaps the answer to your first question. The second one, in terms of a 24-hour admission service, we did stop that at the point of putting this model in place, and the reason being is the example that we've used really is that if we didn't, patients would be admitted to Grantham with either a query status or potentially with confirmed COVID, and that would undermine all of the work that we've done in terms of protecting cancer and vulnerable patients as part of that. And the decision we've got to make in the future is that, knowing that COVID will still be around, but obviously very different risks, is that if we restore A&E and the admission wards, we would be taking a greater risk of patients contracting COVID in Grantham Hospital as a result of that. In terms of the unit that I think your colleague or friend may have used, I think it was the out-of-hours service, which is a brilliant service run by LCHS, who do a lot of sort of enhanced out-of-hours primary care interventions, but they wouldn't, and they have been operating from Kingfisher unit prior to this model. I think in the future we would absolutely want to maintain that service because it does amazing things and prevents people from needing to be admitted in many cases, and that would be part of the restoration of services as part of the front of house, the A&E suite essentially there, and hopefully that answers the remainder of your questions, Councillor.
Okay, thank you, Councillor Gabriel.
Can I come back just 1 minute? I'd like to say...
if you can be quick, please, Councillor Gabriel, because Andrew needs to be away prior to 1.
Yes, it is. I'm being very quick. I'd just like to say thank you very much for being so honest with all those questions and answers. The 24-hour service, can we please have more publicity from all the powers that be on letting the public know in Grantham area and everywhere else that this is available, and also ambulance drivers, if called out, are given the option of taking their patient there rather than taking everybody to Lincoln, please, because if we could get the PR right, which we never seem to, and get the public knowing that there's somewhere there where you've got doctors and people, and usually there are 2 doctors around, they will have confidence in us again. Well, at the moment, I'm afraid it's somewhat lacking. Not as far as COVID is concerned. I think you've done a brilliant job. I think you've done a brilliant job as far as TB goes. The green area goes. Basically, I can't fault any of you. And I think you need to take that back and have a few laurels on that one. Not just me, but any of us. We all admire you, I'm sure, and what you're doing. But somehow or other, you never get the PR right. We never get it over to the Grantham Journal and everybody else that we have got the facilities at Grantham for 24 hours. So thank you very much. That's all I want to say. And thank you very much for trying to answer the questions. I knew I was being a bit difficult, as usual. Thank you.
Okay, thank you, Councillor Cabry-Brown. I'm sure that will have been picked up upon. I'll try and quickly get through my questions. My first is, how much elective surgery has been cancelled at Grantham, and do you expect cancellations to reduce in the coming weeks? I'll let you start with that one.
We have had to reduce down to 60%, so about 40% of what was going through Grantham is currently out of action at the moment. That is to support our ICUs. Whilst that's a big general figure, there are times where we've had to reduce even further than that, depending on what's happened in our intensive care units. We would expect that going back up to in excess of 100% as and when our intensive care units start to reduce their occupancy.
Okay, thank you, which leads me on to my next question. How many staff have been redeployed from the Green site to Pilgrim and Lincoln due to the increased COVID-19 pressures, and what area of care have these staff transferred from?
It's a very difficult one to answer because of the time series. At times, it's probably been very low when we've been running the Grantham Green site. I'm thinking back to the quarterly report, perhaps in September, the redeployment was relatively small. In recent weeks, it has substantially increased and probably matches those figures I've given in terms of elective care, where we may have seen possibly 60+% of the theatres and ward staff who will have been deployed to help in our intensive care units and on our other areas. But it is a very variable thing, so apologies, I can't give you a particularly hard number that covers that time period.
Okay, thank you. And under the current plans, do you intend to bring the X-ray and fracture clinic back within the site at Grantham?
The plans that we're pursuing in recommendation 4, I think in the report, would put all of the services back within the emergency department. So X-ray, fracture clinic. We would also look to move outpatient, out of hours services in that suite as well. So probably slightly larger offer of services in that footprint. And the team are just working through that, the practicalities now of how that would be put back in place.
Okay, and my very final question, how many staff is currently off sick from Grantham, and how is the staff morale there?
Oops.
In terms of breaking it down to just Grantham, apologies, I can't give you that figure straight away. Andrew might, but I don't have those at my fingertips. In terms of morale, it's the same mixed sort of set of feelings that I think Andrew described earlier. I think we've got some Grantham teams who have absolutely loved delivering the incredible services over there in terms of the elective work that we've done. But in recent weeks, they have had to go and work in probably some of the most difficult services anywhere in the NHS in our intensive care units, wearing full PPE for hours at a time, which is particularly difficult. So their morale will absolutely have been affected by the incredibly difficult circumstances that they've been working in. And they've been supported by doctors, nurses, therapists. We've even had support from military technicians working with us as part of our recent efforts in the last few weeks. So it is a real mixed bag. We know it's incredibly difficult for a number of those teams to have, particularly theatre teams, who have had to help in our intensive care units.
Okay, thank you.
The sickness figure for Grantham is 56 off sick, including 12 COVID related. It's not necessarily that they've got COVID, but they might be isolating.
Okay, thank you for answering that, Andrew. In which case, I know you've got to go away. I'll move to the proposal now. So thank you very much for attending.
I think Simon's got to go with me as well. So
that's fine, no problem. Thank you. Okay, in which case I'm going to move to the proposal, and that is to consider the information presented by United Lincolnshire's Hospitals Trust on the second quarterly review of the Green site at Grantham Hospital, and to consider the timing of the committee's next update from the United Lincolnshire's NHS on this topic. I would actually make the recommendation that we have that in our first meeting when we come back with the new council term. So that's proposed. Do I have a seconder? Thank you, Councillor.
I'm happy to second that, Chairman. Thank them as well for a very thorough
yes,
report.
Thank you very much for your attendance.
Okay, bye.
In which case, we'll take it by dissent again. So if there is any dissent, can you please show in the chat box? No, in which case that's been moved. Thank you. Okay, we'll now move on to agenda item 9, the work programme, which you'll find on the report at 93 to 100 on the pages. I'll hand over to Simon Evans. Simon?
Yes, thank you, Chairman. The work programme for the March meeting is set out on page 94 with one item listed, the date in April on page 95. During the course of the sessions on mental health, items 5 and 6, we've taken account that we will receive a monthly update on the arrangements for Ashley House from LPFT. We've also got the CAMS item coming in June. There's also a request for additional report on provider collaboratives, as well as I think Jane Marshall offered additional paper on the personality and complex trauma team. There's a number of things that have come from those earlier items in the agenda. There's one other thing I need to refer to. During the course of this morning, the chairman and myself received an email from the CCG in relation to the Woolsthorpe branch surgery closure. And this closure has been paused, and this is because that a petition was referenced in the report to the Primary Care Commissioning Committee. So whilst the petition was referred to in the report to the CCG's committee, the CCG has not reviewed the petition in line with its processes. So as a result of this, the CCG has made the decision to pause the decision which was made earlier this month in relation to the Woolsthorpe surgery branch closure. So that is all the information I have. I no doubt that could in its own way generate a number of questions. It's a relatively short email, and for the next meeting we should be able to provide additional information. My understanding is that the Primary Care Commissioning Committee is meeting on a 2-monthly cycle. So having met in February, I would assume that their next meeting would be in April, but I will need to check that. Thank you, Chairman.
Thank you, Simon. I have Councillor Brewers first that you'd like to come in. Councillor Brewers?
So I've arrived. It was just to say thanks, Simon, for the update very much. And I think it would be wrong on a busy period now not to thank Trina and Simon for keeping, and yourselves, for keeping us up to date in between meetings with all the things that come in. That helps us very much when people in our area approach us about things, and we can keep them up to date. And I personally would like to move that we accept the programme as it is and thank very much those who keep us up to date. Thank you.
Thank you, Councillor Brewers. Councillor Whittington, you'd like to come in as well, please.
Yes, thank you, Mr. Chairman. I think I'd like to echo comments that Councillor Brewers has just made regarding the support that Trina and Simon give us over the last 4 years. Has been exemplary. It's been really first class. So many thanks. So for all your hard work. And actually, Simon, a perfect example of that is the update you just gave on the Woolsthorpe by Beaver surgery. And obviously, as the division councillor for that, I would be interested in being appraised of updates regarding that, because I was aware that there had been a petition that had been started by local residents and by the parish council. Unfortunately, I couldn't make the meeting on the 10th of Feb, the CCG meeting, so I wasn't aware that the petition hadn't been considered. So it would be useful if we could consider and look at that in March. Just an update on progress. Thanks, Simon. Thank you.
Thank you, Councillor Whittington. I'm sure we'll look at trying to get an update at that point for the committee and yourself. In which case, I think it's been proposed and seconded by Councillor Whittington. We accept the work programme. And yeah, I think it goes absolutely without saying the support of Trina and Simon has been absolutely exemplary. And I think we all appreciated it very much so. Certainly couldn't do the job without the support they give me as well. So thank you all very much for that. Okay, if there is any dissent, please show in the box. If not, we'll carry the work programme forward. No, in which case I would like to...
Mr. Chairman, can I just say something?
You may indeed.
Just added to this, we didn't say thank you, or at least don't remember us doing so, to all the extra staff that have managed to get the COVID injections done. I think whoever's in charge of it has done a brilliant job in Lincolnshire, because at one time we were leading the stake, so to speak, of how many COVID jabs were being handed out. And while I'm able to chat, can I just ask Dr. Wookie something? Dr. Wookie, everybody seems to have had some sort of shivers, shakes and pain or whatever. And I think a comment was made, well, then it will have worked. But I didn't get anything. I mean, is it just that I'm a hard nut, or that I just went in, had a jab, came out and just did not get a thing? I had no shivers, shakes, sneezes or anything. And it's just interesting as to whether it did take or not.
Well, do you want me to answer that?
Only one who had no effect. I had no effect.
Yeah. I had no effect. Angela White, I had no effect either. Neither did my husband. Neither did most of the people we know.
Okay, if Dr. Wookie can respond, and then I'll take Councillor Fido afterwards, please, so it's not turning into a free for all.
Well, I think probably I can't say anything more than anybody else, but I didn't have any effects apart from a slightly sore arm, which is usually get with flu anyway. So obviously, you know, we're a bit tougher, aren't we? Some of us.
I think that's true. Okay. Take that as said. Thank you.
Thank you. Just to respond before I bring in Councillor Fido, we did say thank you to those that are involved in the vaccination programme. It was on the chairman's announcements, and I did make a point of doing so. So that's absolutely fine. Councillor Fido.
Yeah, I mean, I'm just sat here almost with a pang of jealousy because I think I'm right near the very bottom of the queue for the vaccine, but I'm chuffed to bits for everyone that's getting it. And I saw something online the other day that I thought was quite poignant about this. One of the anti-vaxxer arguments is about, oh, but what about the side effects of feeling ill? And the anecdote I saw that said, okay, well, think of it like this. You're going in a car and you're involved in a collision. As long as if you wear your seatbelt, which is the vaccine, yeah, you'll get some heavy bruising and maybe a broken rib or two. But what's the alternative? COVID, which is the equivalent of going through the windscreen, without being overly graphic. And I think I thought it was quite an interesting anecdote in that, you know, yeah, I've seen so much anecdotal evidence about people feeling crap for a day or two. Sorry, pardon my French, but the alternative, which is the strain on the NHS, you know, ICU, needing of ventilators, and most importantly, possibly death, is a much, much worse thing to think about. So I'm really chuffed to bits that I'm seeing my, you know, Facebook and Twitter feed filling up with people I know slowly getting their vaccines. You know, Councillor Wood and Councillor Kendrick, I think I've both seen recently. So I really, really think it's, you know, important to, you know, drive the message that we urge people when you get called for the vaccine, go and get it. Because if I got a text right now saying drive to Gainsborough or Grimsby or Spalding to get a vaccine, I would be there in a flash with my sleeve rolled up like nobody's business.
Thank you, Councillor Fido. And that was an excellent analogy, and we will take your technical term as well. It can be accepted. Thank you. Okay, any further comments? No, in which case I'd like to thank you all for your attendance and taking part in an excellent meeting as normal. I do appreciate all your comments. So thank you all very much, and I look forward to seeing you at the next meeting. Take care, everyone.
Thank